I will take you through the introduction today. So the introduction. Right. Okay. So others may be joining on the YouTube facility. Right. So I'm just going to give you a small introduction on of the pediatric emergencies, how the program runs. So what you're trying to do is you all come from different backgrounds, like from the local universities, different overseas universities. So you have been sort of now given the appointment as pre-intern doctors. So therefore, we have to sort of get everybody on a common platform. Like we need to sort of get the expert to speak to you on what they expect in their different specialties. So this is what we are trying to do in pediatrics. I'm going to give you some overall view on what you need to look into or achieve when you start doing the pediatrics. So the basic objective is that to introduce some effective and stabilization principles in children with life-threatening emergencies in the pediatrics. So this is based on two books. One is the Advanced Pediatric Life Support Manual, which is about 15,000 rupees, and also the Pediatric Basic Manual, which is about 1,000 rupees, which you can buy it from the college office. Then we also have an online facility, but you need to request separately for this online facility. Once Roshan sends, we can share with this. And for the troubleshooting, these are the emails and the mobile number they can. And so these are the online recorded lectures in this website, so that you can go to the website and then get the access to these lectures, online recorded lectures. And also there are online video demonstrations where you can see all the videos. And this is the college website. If you type slcp.lk website, then you get into this site, and then you have this APLS manual 6th edition you can download. And these are the differences. These are the dengue guidelines, new dengue guidelines, pediatric dengue guidelines after enrollment. And this is the STP in pediatrics, standard treatment protocols. So these few copies you can download from the web freely without any issue. So for the Zoom sessions, we need a good internet connections. You can switch on the web camera if questions if you want to ask questions. Otherwise, keep the mic muted. If you don't keep the mic muted, everybody will get disturbed. So therefore, keep the mic muted during. So we don't ask you much questions because there's a big crowd. So this is almost like lecturing in your universities, not small group discussions. If disconnected, you may rejoin again. And if you need to raise a question, please raise the hands or you can type it in the chat box. And sometimes some of the instructors may put some polls projected during the sessions. And also the important thing is at the end of all the sessions by all the colleges, we will send you an online MCQ paper, a very simple MCQ paper where you need to answer and also a feedback form on the program, so that we can you can suggest the areas for improvement and how you would effectively conduct this program. Of course, there are limitations because when there are about 300, there are more than 1,000 pre-interns joining this program. It's very difficult to pass the message what we should be passing, but I think we'll try to do maximum during this session. So what we want you to is mute the mic and patiently hear the here here try listen to the lectures and then type your questions here. Okay, so thank you. I think that's all. So the format for pediatrics online for lectures and well, I think that we have told you, and the ministry will issue a certificate at the end of the session. So thank you very much. We'll start the program. Okay, so Chamodi. Chamodi, are you here? You can open it. Hari. I can go. Oh, screen share like tama lecture ko puno nani.
හරි. දැන් ඇහෙනවද? මම ඔක්කොම මේ ෂෙයා කරා.
I'm Dr. Shamila Tisera, consultant pediatrician, and I will be speaking to you on basic life support. The objectives of this lecture is to understand the structured approach to basic life support, to learn the sequence of basic life support, and to describe the skills to be acquired. Different techniques used in resuscitation varies according to the child's size. As a result, the pediatric age group we divided into three: the newborn, the infant we consider from 1 month to 1 year, and child 1 year to puberty. The rescuer should use pediatric guidelines
Hello, sir.
if he or she believes the victim to be a child.
ඒක සර්
If the
ලේසි
victim
නං.
is in fact a young adult, there's no harm in resuscitating according to pediatric guidelines, as hypoxia and not ischemia is often the cause of cardiac arrest in this age group as well. The definition of basic life support is to restore the circulation with oxygenated blood following sudden pulmonary and or cardiac arrest, and you don't need any equipment. The important thing is the adequate knowledge and skills on how to do basic life support, and this can be done in any situation. It doesn't have to be only in a hospital setup, and the important thing is that it has to be done immediately the moment you find the person who is in cardiopulmonary arrest. It is important that the rescuer wear the recommended personal protective equipment prior to resuscitating a victim. All of the listed personal protective equipment would be available in hospital setup. We don't want the rescuer to carry the infection to the community, and also we do not wish the rescuer to be another victim. So therefore, make sure you wear the necessary personal protective equipment that is available prior to resuscitating a victim. In pediatrics, we consider hypoxia as a major cause of cardiopulmonary arrest, and therefore we give priority to airway and breathing over circulation. In APLS, we resuscitate victims on the ABC approach. A is for airway, B for breathing, and C for circulation. When performing basic life support, we follow the DRS approach. D stands for danger. It is important that we take the victim away from ongoing dangers, and also we do not wish the rescuer to be another victim. A good example is when resuscitating a victim of a road traffic accident, we would not be doing so in the middle of the road, but we would do basic life support in a safe place. So therefore, it is important that we take the patient to a safe place prior to starting basic life support. Once we've done this, we check for the responsiveness of the patient. We do this by placing our hand closest to the patient on the patient's forehead. Therefore, we can stabilize the C-spine as well. And with the other hand, we can shake the patient's hand or give a stimulus to the sternum and see the responsiveness of the patient. If the patient is unresponsive, we need to shout for help. By doing this, we try to get the attention of people who are passing by so that they could get help for us. It is important that we get this victim to a hospital as soon as possible, because to perform basic life support for a long time is a tedious task. Once we have completed the DRS approach, we need to now attend to the airway. An obstructed airway may be the primary problem, and correction of the obstruction can result in recovery without any further interventions. Often, the commonest cause of airway obstruction is the tongue falling back, and next would be secretions, and very rarely it would be a foreign body that is obstructing the airway. The rescuer now should make an attempt to open the airway by performing the head tilt chin lift maneuver. The rescuer should place the hand closest to the child's head on the child's forehead and apply pressure to tilt the head back gently. One or two fingers of the other hand should now be placed under the child's chin and lift the chin up gently. Make sure the fingers are placed on the bone and not on the soft tissue. By gripping too hard on the soft tissue, it would damage these tissues, and also by compressing the tissues upwards, it could cause an upper airway obstruction. The degree of head tilt chin lift will vary according to the child's age. The desirable degree of head tilt chin lift is neutral in an infant and a sniffing position in bigger children. In the neutral position, the child's ears will be parallel to the surface they are lying on, whereas in the sniffing position, the neck needs to be extended slightly more as if smelling a good smell in the air. In a child suspected of C-spine injury, we perform a jaw thrust instead of the head tilt chin lift. In order to perform the jaw thrust, one or two fingers should be placed behind the angle of the mandible bilaterally, and the jaw should be lifted 90 degrees upwards without changing the position of the patient. Once the airway opening maneuvers have been performed, the rescuer now needs to check the patency of the airway. The rescuer should look, listen and feel for 10 seconds to see if the child has spontaneous breathing. This is best achieved by the rescuer placing his or her face above the child's face. The rescuer's ear should overlie the child's nose, and the rescuer's cheek should be overlying the child's mouth. His eyes should be looking towards the child's chest and the abdomen, and to see if there is abdominal movements and chest expansion with breathing. If the child is breathing, the rescuer should feel the breath on his cheek and should be able to hear the child breathing. If the patient does not have any spontaneous breathing, or if the breathing is ineffective like gasping, the rescuer should start expiratory rescue breaths immediately. Here we'll be discussing how to give expiratory rescue breaths while keeping the child's airway open with a head tilt chin lift or jaw thrust. The rescuer should take a deep breath and seal his or her mouth around the victim's mouth if it is a child, or the mouth and the nose for an infant. When giving rescue breaths to a bigger child, the rescuer will be sealing his or her mouth around the victim's mouth, and the nose has to be pinched closed with the index and the thumb of the hand that is maintaining the head tilt of the child. When delivering the rescue breaths, make sure it is given as slow exhale breaths, and the victim's chest should be seen to rise visibly. And also, in between the breath, rescuer should take a deep breath to maximize the oxygenation of the victim. Once two good chest expansions have been achieved, we can now move on to circulation. The failure of circulation is recognized by the absence of signs of circulation and absence of pulse. Now, checking for pulse in infants is usually done over the brachial artery or the femoral artery. Infants have very short necks, and therefore it's very difficult to palpate the carotid arteries. In bigger children, we check the pulse over the carotids, and also we could use the brachial and the femoral arteries to check the pulse. We need to check the pulse for 10 seconds. If there is no pulse or slow pulse or no signs of circulation, we need to then start chest compressions. What are the indications for chest compressions? Absence of breathing, no central pulse for less than 10 seconds, and no signs of life. A victim is considered to have no signs of life when he or she has no movements and there is no cough or gag reflex even when rescue breaths are delivered, and when the skin is found to be pale, mottled, and bluish in color, which indicates there is very poor circulation. In order to deliver effective chest compressions, the victim should be lying flat on his or her back and should be on a hard surface. The chest compressions are delivered onto the lower half of the sternum, and in between the compressions, make sure that the chest wall fully recoils before the next compression. This will ensure that the coronary arteries have adequate blood flow. The technique of performing chest compression will vary according to the child's age. In infants, chest compression is effectively given by the hand encircling technique. In this technique, the rescuer holds the infant with both his hands, fully encircling or partly encircling the chest. The thumbs are placed over the lower half of the sternum, and then compressions are carried out on the lower half of the sternum. This method is possible when there are two rescuers, since it will take some time for one rescuer to go back to the airway and reposition and then come back and do chest compressions, which is time consuming and therefore not ideal for a single rescuer. When there's only one rescuer, the two-finger technique should be used to give the chest compression. The rescuer needs to place two fingers over the infant's lower half of the sternum and give adequate chest compression, making sure 1/3 of the depth of the chest is compressed with each compression, and the other hand is used to keep the airway open in the neutral position. When delivering chest compressions to bigger children, single-handed or double-handed technique can be utilized, and this can be solely decided by the rescuer according to his body size and that of the victim. The heel of the hand should be placed over the lower half of the sternum, making sure the fingers are lifted up in the air and not touching the ribs. The rescuer should position himself vertically above the child's chest and making sure the arms are straight. Compressions are carried over the lower half of the sternum, making sure at least 1/3 of the depth of the chest is compressed. The compression rate for any age is 100 beats per minute, and the ratio is 15 compressions to 2 breaths in any age group. Research on the delivery of CPR has shown that rescuers do not give adequate chest compressions. Either it's given too slowly or too gently. So the current emphasis is that CPR should be delivered as hard and fast as possible. When giving chest compressions, always make sure that 1/3 of the depth of the chest is compressed with each compression. This is a very important aspect when delivering chest compressions. Once 1 minute of continued CPR has been given, and if no help has arrived, the rescuer will need to stop and then go in search of help. If the victim is an infant,
The baby can be carried by the rescuer giving CPR while going for help. Once effective BLS is being continued, in our hospitals there are many airway adjuncts which can be used to keep the airway open, like Goodell's airways, nasopharyngeal airways, and ET tubes. And also, in order to give oxygen, we use ambu bags. Often the patient would be attached to a cardiac monitor with a defibrillator, and if there is any arrhythmias, this could be detected early and necessary actions can be taken. While effective BLS is being continued, we need to then insert an oropharyngeal airway and start ambu ventilation with high flow of oxygen. It is recommended to start oxygen at about 10 to 15 liters per minute. Next, it's important that we attach the pads or the electrodes of a defibrillator and start the external defibrillator device. Often there'll be a voice command directing the rescuer on how to operate the machine. Automatic external defibrillators are found in most hospitals in Sri Lanka, and also some of the ambulances are also equipped with this machine. You might find the automatic external defibrillators in some of the latest buildings that have been built in the city of Colombo and outstation. It is important that the rescuer knows how to operate these machines, and also the automatic defibrillator should be used when necessary as early as possible. This slide gives us a good summary of all what we have discussed earlier. Early recognition and calling for help, and then starting good quality CPR would prevent the patient going into prolonged cardiac arrest. This would buy us time until help arrives. Some studies have shown that children above 8 years who arrest suddenly often have pulseless VT or VF, and it is also found that delay in every minute would reduce the chances of survival by 10%. So therefore, it is very important that early defibrillation should be commenced on these patients. Let's now quickly run through the algorithm of basic life support. So D stands for danger. R, responsiveness of the patient should be checked. S, if patient unresponsive, we send for help. Next, we start resuscitation, and priority is airway. So A, open airway. B, check for breathing, and if no breathing, give 2 rescue breaths. Next, we check the circulation, and if the child is found to have no pulse, slow pulse, and no signs of circulation, we start cardiac compressions, 15 to 2, and should be 100 per minute. Next, the patient should be attached to the defibrillator, and if found to have VF or pulseless VT, early defibrillation is very important. If the patient is found to have recovered with return of spontaneous breathing and circulation, the patient should be placed in a recovery position. There is no specific recovery position that has been identified. The child should be placed in a stable lateral position, which could be on the left or the right side, and ensure that the airway is always kept open with free drainage of fluid from the mouth. The cervical spine should be well stabilized with minimum movement, and the rescuer should have adequate access to the patient in order to continue the monitoring, which is essential.
In APLS, the choking child is also considered as part of the BLS lecture. And so therefore we'll be discussing about the foreign body airway obstruction. Majority of the deaths from foreign body airway obstruction occur among the preschool age group. Often these foreign bodies are food particles, or it could be little pieces of plastic from toys. The diagnosis of foreign body airway obstruction might be a witnessed event where an adult sees a child choking on a piece of plastic or food, or it has to be highly suspected when a well child suddenly develops difficulty in breathing with coughing, gagging, and stridor. Let's now discuss the algorithm one has to follow if encountered with a choking child. It is important that the rescuer assesses to see whether this child has effective coughing or not. In a child with effective coughing, it is important that the rescuer encourage this child to continue to cough, because spontaneous coughing is the most effective method of relieving an obstruction as compared to externally imposed maneuvers. An effective cough is recognized by the victim's ability to speak or cry in between the bouts of cough, and the rescuer should continuously assess the child and make sure the child is not left alone at any stage. If suddenly the child becomes silent and does not speak and finds it difficult to breathe, becoming cyanosed or lose consciousness, then it is important that you follow the algorithm that is for unconscious child with ineffective coughing, which is the basic life support that we have discussed so far. In a child with ineffective coughing but who is conscious, then we have to follow the algorithm where we deliver 5 back blows and 5 chest thrusts. We do not perform the Heimlich maneuver like what we would be doing for adult who is choking, and also we do not perform the blind finger sweep of the mouth or the upper airway, as this could damage the soft tissue and result in bleeding. Always inspect the airway under direct vision, and if the foreign body is visible, it should be taken out by the rescuer. In children, the thoracic cage does not cover the upper abdominal organs like the liver and the spleen, and so when performing Heimlich maneuver, it could damage such organs in the pediatric group. So therefore, the Heimlich maneuver is not recommended in the pediatric age group. Let's now discuss the external maneuvers of back blows and chest thrusts that need to be done on a child who is choking, who's conscious and does not have effective coughing. As depicted in the picture, the rescuer should place the baby along his or her arm in a head down position. The rescuer's hand that is supporting the child should then open the infant's jaw in such a way to keep the airway open in a neutral position. Since the baby's weight would be difficult to carry on one arm, the rescuer should support his arm by placing it along his or her thigh. With the heel of the free hand, the rescuer would now give 5 back blows in between the 2 scapulae, and then turn the child over and look into the airway and mouth to see if the foreign body is visible. If it is not visible, then 5 chest thrusts need to be delivered. The 5 chest thrusts are given onto the same place where cardiac compressions are delivered, that is the lower half of the sternum. If the child is too big to be carried on the arm of the rescuer, then the child could be placed across the rescuer's lap, and the 5 back blows and chest thrusts can be delivered as described before. Continue to do this maneuver while taking the patient to the nearest hospital with ENT support. Let's now summarize on what we have discussed in this lecture. In basic life support, we approach a patient safely, that is DRS, and then we resuscitate them according to the APLS algorithm, which is ABCD, and then we continue BLS until help arrives. Then coming to choking child, we follow the algorithm, and it's important that we detect whether the child has effective coughing or not, and if they are conscious or unconscious, and then resuscitate accordingly. So therefore, we conclude the lecture on BLS and choking child. Thank you very much.
Critically ill child. The objectives of today's lecture would be to understand the structured approach to airway and breathing in a critically ill child, and to introduce the equipment used to manage the airway, and to describe the skills which needs to be acquired in managing a child's airway. During the lecture today, we will be discussing on the following aspects of airway management in a child: the basic airway opening maneuvers, the airway adjuncts, the steps of intubation, and options for failed intubation. This will include the ordered sequential response and the simple techniques which are effective and life-saving, and also the other important steps that we can take when there's a failed intubation. Before discussing about the airway management in children, I want to highlight a few anatomical differences between a child and an adult, because this will be important in managing the airway. In younger children, especially the infants, they have a large occiput, which can cause the neck to be flexed and can cause upper airway obstruction. That's why we always encourage to keep a shoulder roll for children of less than 2 years of age when managing their airway. And in young children, they have a relatively larger tongue when compared to the oral cavity, which can fall backwards and cause further upper airway obstruction. And in young children, the larynx is more high and anterior when compared to an older child or an adult. And also the epiglottis is more floppy, and these anatomical differences makes it a little more difficult in managing the airway in children when compared to an older child or an adult. Positioning of the airway in children. So in children of less than 1 year of age, infants, the airway opening position is the neutral position, as you can see on the first picture, where the face is parallel to the ceiling. The eyes are parallel to the ceiling, and there's no undue extension or flexion of the neck. In a child of more than 1 year of age, we maintain the airway in the sniffing position, as you can see on the second picture. You do a small head tilt and a chin lift and maintain the airway in the sniffing position of a child older than 1 year of age. There are 3 basic airway opening maneuvers: head tilt, chin lift, and the jaw thrust. As you can see on the first picture, with one of your hands, you can do the head tilt. You can keep the hand on the forehead of the child and do a small tilt. And with your other hand, you can do the chin lift and maintain the airway in either the neutral position or the sniffing position, depending on the child's age. When the airway cannot be opened by these 2 maneuvers, we can go for the jaw thrust, as seen on the second picture. This is an important maneuver to learn, because there are instances where you cannot do the head tilt and chin lift, such as where you suspect a cervical spinal injury. In those instances, the jaw thrust would be a better maneuver to maintain the airway in a critically ill child. During the jaw thrust, you use both of your hands and keep the fingers on the jaw of the child and stabilize the cheeks with the thumb. And your aim is to push the jaw upwards and maintain the airway in a jaw thrust maneuver, as you can see on the second picture. There are various types of airway adjuncts that we use in a critically ill child to maintain the airway open. So first airway adjunct we are going to discuss is the oropharyngeal airway. So before inserting an oropharyngeal airway, you need to get the correct size of the oropharyngeal airway. So you size it by, as you can see on the first and the second picture, from the center of the mouth to the angle of the jaw. So from the center of the mouth to the angle of the jaw of the child, and that would be the ideal size for that specific child. And you need to keep one size smaller and one size bigger, because as you go in, sometimes you might feel the size is not exactly correct. So when you are inserting the oropharyngeal airway, it's better to do it under direct vision by using a tongue depressor or even your laryngoscope. And you insert it along the same anatomical pathway as your posterior palate, and you depress the tongue more than rotation, and you slowly insert it along the posterior palate of the mouth. The next airway adjunct is the nasopharyngeal airway. This is not as commonly used as the oropharyngeal airway, but there may be certain instances that you might have to use this. For example, if there is significant trauma to the oral cavity, you might not be able to insert an oropharyngeal airway. Again, before you insert the nasopharyngeal airway, you need to get the correct size of the airway. So how do you get the correct size? The correct size of the nasopharyngeal airway is, the length is from the lateral edge of the nostril to the tragus of the ear, as you can see on this picture. Lateral edge of the nostril to the tragus of the ear. And the diameter of the nasopharyngeal airway is of the little finger of the patient or the diameter of the nostril. So nasopharyngeal airway insertion is a little cumbersome procedure and might be uncomfortable for the patient. So before insertion, you need to lubricate it well, and then, as shown on the picture, direct it posteriorly rather than upwards, and slowly insert it along the nasopharynx. The most important drug that we are going to deliver for a critically ill child is oxygen. In order to prevent hypoxia in a critically ill child, oxygenation is very, very important. And wherever you work, if you find a critically ill child that you need to resuscitate, you need to deliver the highest available oxygen concentration which is available at your hand. Usually, this can be about 10 to 15 liters per minute. So the oxygenation for a child can be done by using various equipment. As you can see on this picture, you can use a Venturi mask where you can deliver a specific calculated amount of oxygen per minute. And in young children, especially infants of less than 2 years of age, you can use the nasal cannula or the nasal prongs, as you can see here. Usually the maximum amount of oxygenation that you can deliver through the nasal prongs is about 2 to 3 liters per minute. There are the normal face mask can also be used to deliver a higher amount of oxygen concentration. Oxygenation can also be done by using other advanced equipment such as the neopuff, the CPAP, and the BiPAP. The neopuff is usually used for newborn resuscitation and for managing critically newborns in the NICU. As you can see on the first picture, you can deliver a specific amount of oxygen to the baby, and this is a more advanced method than the traditional bag and mask that we use for neonatal resuscitation. You need to deliver an exact amount of pressure which you can give through this, and that can provide effective oxygenation in newborn resuscitation. Continuous positive airway pressure, as you can see on the second picture, is also used to deliver a specific amount of oxygen concentration in the ICU or the high dependency units, especially for young infants in conditions such as bronchiolitis and other respiratory issues. BiPAP is not very commonly used in children, but also is used amount of concentration, oxygen concentration. Bag and mask ventilation is one of the most important steps that we need to learn in order to effectively resuscitate a critically ill child. This will provide an effective oxygenation to the child until help arrives or until you go on for the next proper airway management. There are various size bags and masks to be used in children, and usually in newborns we use a bag of about 250 ml of volume, and for an older child it's about 400 ml. And then the TP's ventilation is not commonly used during resuscitation, but commonly used by the anesthetist for various procedures done in children to provide some ventilatory breaths for a short duration. Before giving the bag and mask ventilation, you need to choose the correct size mask according to the child's size. The ideal mask should cover both nose and the mouth, but it should not go beyond the eyes and it should not go beyond the chin. So as you can see on this picture, this is the correct size mask for this child. If you use a too large mask, then the air escapes from below the chin and your eyes can get damaged. If you use a too small a mask, then your nose and mouth is hardly covered and you might not deliver the effective oxygenation to the child. Positioning of the mask is done by using the C and E method as shown on this picture. So the mask should cover both nose and the mouth, and you can use one hand in the form of the C and E method. So your index finger and the thumb is holding the mask tightly in the form of a C letter on the alphabet, while the other three fingers of your hand in the form of an E letter is holding the jaw, like in a jaw thrust maneuver. When you are doing this, remember not to unduly press on the throat area because that can cause upper airway obstruction. So this is the proper way of positioning of the mask before providing effective bag and mask ventilation. Bag and mask ventilation, the main aim is to give a volume of ventilation enough to produce an obvious chest rise. So it can be done by a single rescuer or ideally by more than one rescuer. So if you are the only rescuer available, you can give the bag and mask ventilation by yourself. From one hand, you can position the mask and hold it in the C and E position as shown on this picture, and then give the ventilatory breaths through the other hand. But you always have to look at the chest of the patient to see whether there is an obvious chest rise. When there's a single rescuer, this can be done for a short duration of time, but you cannot do it for a longer duration, and it can become less effective and difficult if you are the only rescuer. If you have another helper, then of course you can hold the mask. One person can hold the mask with both hands using the C and E position while looking at the chest, while the other person can give effective ventilatory breaths. This is the more effective and the easier method, and you can provide effective ventilatory breaths for a longer duration of time. Steps of intubation. So intubation is a skill that we all should learn, but it's not an easy skill to learn. To do an effective intubation, at least 4 members has to be there on the team. The team leader, and there has to be one nurse who is in charge of IV access and drugs, another nurse for the equipment used, and there should be a running person helping out the other members. So the main steps of intubation is pre-oxygenation. So the aim of pre-oxygenation is to get the oxygen concentration to a higher amount, at least more than 93%, before you start your intubation. So you do this by giving effective bag and mask ventilation. In children, as I have already mentioned, their larynx is high and anterior. So there has to be some person providing cricoid pressure in order for the team leader to do the effective intubation. All the drugs, the boluses and everything has to be predetermined according to the age and the weight of the child. And avoid ventilation if possible, but of course there are instances that you need to intubate and ventilate. In those instances, get all your things ready and intubate immediately without any delay, avoiding hypoxia of the patient. And once the tube position is confirmed, you can release the cricoid pressure. So as I have already mentioned, pre-oxygenation is where you get your oxygen concentration of the patient to a higher amount before attempting intubation. So you need to keep the child attached to the monitors, the pulse oximeters and the cardiac monitors, and provide effective bag and mask ventilation using the previous methods that we have discussed, and give effective ventilatory breaths for a couple of minutes until you get your oxygen saturation to a reasonable level. The nurse who is in charge of drugs should make sure that all the drugs are drawn according to the body weight and the age of the child. There are various drugs used prior to intubation, and it depends on each unit and the consultant as well. The usual drugs we use is a sedative, an induction agent, and a muscle relaxant. And you also need to make sure that all your resuscitation drugs, such as adrenaline, are ready, because sometimes the patient can go into a collapse during your intubation. And your fluid boluses also need to be ready, because the patient can suddenly become hypotensive during intubation. The nurse who is in charge of equipment should make sure that all the equipment are functioning. Battery life or connected to the electricity, and you should have the laryngoscope in place. Usually we use the straight blade laryngoscopes for younger children and the curved blades for older children. And your endotracheal tubes of various sizes according to the child's age and the weight, which we will discuss in the next slide. And your suction apparatus and the suction tubes. And all other equipment should be ready prior to the attempt of intubation. And the nurse who is in charge of equipment should make sure that these are ready. Is determined by age divided by 4 plus 4 for an uncuffed endotracheal tube. For example, if the child is 8 years of age, 8 divided by 4 is 2, 2 plus 4 is 6. So size 6 millimeter would fit for an 8-year-old child. But you always need to have one size above and one size below, because once you start intubating, you might realize that the size you are having at hand is not the exact size. For a term infant, the endotracheal tube is about 3.5 millimeter. For an older child, it's about 4 millimeter. And if it is a premature infant, the size is usually about 2.5 millimeters. The lip length of the endotracheal tube is calculated by age divided by 2 plus 12. So if the 8-year-old child, it's 8 divided by 2 is 4, 4 plus 12 is 16. So the lip level should be at 16. Steps of intubation.
Okay.
So prior to intubation, you need to make sure that you have pre-oxygenated the patient well and the saturations are at a reasonable level above 93%. And you can start using your laryngoscope and make sure that the laryngoscope is working before you insert it. And you push the tongue to one side and advance the laryngoscope further down. Once you come to the epiglottis or the vallicular level, you might not visualize the epiglottis and the airway because of the high and anterior larynx in young children. That's why another person needs to apply cricoid pressure as shown on this picture. By applying cricoid pressure, the epiglottis and the airway will be more visible. So once you visualize the epiglottis and the airway, you know that you are in the correct place. Once you see this, you need to start intubating using the correct size endotracheal tube. And you slowly advance it further down while withdrawing the laryngoscope outwards. Of course, this is easier said than done, so that's why it's always important to practice this skill whenever possible. So intubation might fail due to various reasons, but to make sure that you don't forget certain steps of intubation, there's a mnemonic called SOAP ME. So S stands for suction. You need to make sure that the suction apparatus is working and proper suctioning of the patient, especially if there are secretions. Oxygenation, pre-oxygenation, and checking for oxygen saturation. A is for airway adjuncts. While you get your equipment ready, you can always consider using an oropharyngeal airway and also keep the laryngeal mask airway at hand because you might fail the intubation. P is for positioning and pharmacology. So positioning of the child according to the child's age. Less than 1 year, it's the neutral position. Above 1 year, it's the sniffing position. Pharmacology indicates all the drugs that you are going to use at the intubation. M is for monitoring. Check all your equipment, the cardiac monitors, the saturation monitors, all should be working. And E is for escape plan and your proper size endotracheal tube. So you need to have a plan for failed intubation before you start intubating. After insertion of your endotracheal tube, you can confirm the position by various methods. First thing is to confirm the position clinically. You can see a nice chest expansion and your equal air entry when you listen from the stethoscope, and your saturations will start going up. You need to check for air leak on either side of the neck. And also you can confirm the position by using a carbon dioxide monitoring device. In uncuffed tubes, there might be a small leak. If you are using a cuffed tube, which is not commonly used in young children, make sure that it is not overinflated. Because if overinflated, that can cause damage to the airway and laryngeal edema. And once you confirm the position, finally, you can confirm the position by taking a chest X-ray. So always remember, oxygenation is the most important step in airway management in a critically ill child. Before intubation, after intubation, and even after failed intubation, keep continuing to deliver proper oxygenation to the child to avoid hypoxia. Nasal intubation is not commonly used in children, but there might be children who have significant trauma to the oral cavity where you might have to put a nasal intubation to maintain the airway. If you have failed your intubation in 2 attempts, please continue your oxygen via bag and mask ventilation. Please don't hesitate to call for help. And always consider airway adjuncts. such as the laryngeal mask airway, and also consider using other equipment such as the introducer or the bougie, or if final step is the surgical airway in failed intubation. And if you have failed in all the above other measures, you need to consider about a surgical airway. So this is the algorithm for rapid sequence induction. So you do a direct laryngoscopy and start intubating, as we have already discussed in the previous slides. If you succeed, then you need to confirm the tube position and continue to ventilate the patient. If you have failed in your first attempt, please call for help and start manually ventilating. If you can manually ventilate, reposition the patient and do one more attempt of direct laryngoscopy. If you succeed, then confirm the tube position and continue to ventilate. If you are unable to manually ventilate this patient, then you need to start inserting a laryngeal mask airway, and through that you can provide ventilatory breaths. If that is working, then maintain ventilatory breaths until advanced airway techniques are being done or until help arrives. If the LMA is also not working, then you need to consider a surgical airway. This is called the vortex. So emergency surgical airway is here, but that is the last step that we are going to undertake in managing the airway. So your first step is effective ventilation through face mask, and then try endotracheal intubation. If unable, you need to make sure that you are going to get a supraglottic airway by using a laryngeal mask airway. So maximum 3 tries at each non-surgical airway technique, and at least 1 try should be by the most experienced available clinician. So maximum 3 tries at each of the non-surgical airway techniques, and at least 1 try of these should be by the most experienced person. If all these methods fail only, you will go for an emergency surgical airway and get the surgical or the ENT team involved. Laryngeal mask airway is another skill. Insertion of a LMA is another skill that we need to learn, because in a person who is, if you're unable to intubate or if you're unable to manually ventilate, LMA is a source of a source that you can provide oxygenation until further help arrives. So again, LMAs, there are various sizes according to the body weight and the size of the child. So you use the correct size, and with your index finger, so first of all you lubricate the end, and then with your index finger you slowly advance the LMA along the posterior palate of the patient. Before inserting it, you need to make sure that the cuff is deflated. Then you advance it further down, as you can see on this picture, with your index finger. You need to maintain the airway, as you can see here, in the correct position while you are inserting the LMA. Advance it further down, and at one point you will feel sort of like a give way sort of a feeling, and then you know that it's lying at the level of the epiglottis and the airway. Once you are at the correct position, you inflate the cuff and make sure that this lies in the correct place, and then you can connect your bag, the bag to the end of the tube and continue to ventilate through the LMA until further help arrives. There are rare instances where you cannot intubate or cannot oxygenate, which is actually quite rare in our setup. You might have to use various high-end equipment as shown on this picture, but I'm not going to elaborate on this, because usually this is quite rare. And then the final option is a surgical airway. Can't intubate, can't oxygenate. Then you need to inform the surgical team or the ENT team and get a surgical airway in to maintain the oxygenation. So in summary of airway management in children, bag and mask ventilation and intubation are the most important skills that you need to learn, but these skills require time and practice to master it. And please never hesitate to call for help, even though you might be the most senior person in the unit at that moment. If you are not sure whether you can intubate, please never hesitate to call for help. And also have a plan for failed intubation before you start intubating. Ventilate as necessary and don't be afraid to assist. Maybe even to a junior person, don't be afraid to assist. And monitor effectiveness clinically and also by your other equipment to see whether you have effectively managed the airway in the critically ill child. Thank you.
Thank you, Madam, for that detailed lecture. So if you all have questions, those who are joined can type in and ask few questions. That was Dilusha Tukorala, consultant neurologist at teaching hospital at LRS. So you all have questions? Right. The next lecture is by Dr. Brinda Sivakantan on lecture on cardiac arrest, asystole and defibrillation. So over to you, Dr. Brinda.
Hello.
Yes, Dr. Binda, you can start. We have given the introduction.
The thing is, from this computer, it is not allowing me to share the videos.
We have made you co-host. You'll be able to do that. Will you try again? Close all the existing presentation and open them freshly and start to share.
Okay. The computer, I think, got stuck.
Oh,
Yeah, I will speak to Chamodi and come back.
okay.
APLS instructor. For the next half an hour, I'm going to talk on the management of cardiac arrest. So we all have gone through the lecture on BLS, basic life support. That is when the patient arrested, you all will start out with basic life support in order to maintain the vital organ function. But in a hospital setup, we will move on to see how we can manage the cardiac arrest in an advanced way. So this lecture will take you through the structured approach to cardiac arrest. So if you know a structured approach, it is easy for you to jump into the scene and immediately start that structure. So usually the airway, breathing, circulation, ABC is the structured approach we follow in any emergency in pediatrics. To describe the protocols to be used, here we are using the Australian, New Zealand version of Advanced Pediatric Life Support Protocol. These protocols are for the initial approach of any emergencies. These are revised every five years, and this one is about to revise, but this is the current algorithm I'm going to introduce in this lecture. Then to introduce the drugs and equipment used during the emergency. So if you know the drugs and equipment used during the emergency, it is easy for you to handle it quickly and effectively. So you should know all the drugs which are needed for the emergencies. Right. So we will move on to the lecture. So when it comes to an arrest, so once you detect the arrest, you will start off with the basic life support. You know DRS approach, then you will secure the airway. So opening up airway, so smaller infant and pediatric patients, then you will give the oxygen and you will move on to assess the breathing. And once the breathing is corrected, then you will move on to assess the rhythm. So here the cardiac monitor comes in and you have to attach the cardiac monitor and you will continue the CPR. So once the cardiac monitor is ready, you have to stop the CPR. So once you stop the CPR, you could be able to analyze the rhythm, whether it is a shockable rhythm or non-shockable rhythm. So we will pause for a while before moving into the algorithm, and we will see why this arrest occurs in children, right? So in children, there are several reasons, but these are the common reasons, 4 H's and 4 T's we say. And the first reason is hypoxia. So if a child found arrested, most common reason is hypoxia. So they are more prone to respiratory component compared to cardiac component. So the hypoxia is the one we will try to correct it first. So airway opening techniques should be considered, and you have to see whether the chest is moving up and down while you are ventilating. So if you have a good adequate expansion in the chest, you are happy that you are giving oxygen. Make sure your bag and mask is connected to the oxygen cylinder. The cylinder should be full. So if you can maintain the expansion of the chest at that point, you are happy. If not, you have to go for the positioning of the child. And if you are able to open up the airway and if you can maintain the chest expansion, then you are happy. If not, you have to go for the adjuncts and you may need to go for the permanent airway insertion. So this is the order you have to approach the airway and make sure the chest expansion is coming up nicely. So that is how you will make sure correct the hypoxia. Then the hypovolemia. So children can present with arrest due to hypovolemia. Hypovolemia can be due to vomiting, diarrhea, poor oral intake, right? So excessive urine output. So all these things, and maybe due to bleeding in trauma and any other reason, septic shocks and third space fluid losses. So you have to find out the reasons for hypovolemia, and you can ask the mother whether there is any evidence of these things, and if it is there, you have to immediately correct the hypovolemia. So if you want to correct the hypovolemia, you need to insert the cannula. So white bore cannula, which is suitable for the age, and find a good vein, proximal vein. Can able to cannulate, then within three minutes, that is all right. Otherwise, you may need to go for a intraosseous if you can't cannulate with 2 tries. So either option is available. So once you do that, you have to immediately take blood for investigation. So full blood count, electrolytes, sugar, and other VBG, maybe you can send for that. And if it is trauma, you may need to send for grouping and DT. So these are the basic investigation we will do in any emergencies while cannulating a patient. So once you send the blood, you may need to take back the results. It is very important because there are some corrections we may need to do to correct the 4 H's and 4 T's. So hyperkalemia, hypokalemia, all these things you can find out from the blood report. So tracing back the reports are very important. As house officers, you may need to do this in your teamwork. Right. So once you identify the reasons for hypovolemia, you should fill the patient with fluids. So always normal saline is the option, and 20 ml per kg normal saline bolus should be given to the patient. If it is trauma, you can give blood if it is readily available. Otherwise, normal saline is the fluid we are giving. But if a child is having congenital heart disease or related problems, what you can do is you can reduce the fluid amount, make sure 5 ml aliquots or 10 ml aliquots, and make sure that you are giving the adequate volume needed for the child's problem. So that is how you will correct the hypovolemia. and start a maintenance drip, and then move on to see the other causes. So hyperkalemia, hypokalemia, hypoglycemia. So all these metabolic causes need to be checked, and immediate correction is very important. Otherwise, this cardiac arrest will persist for a long time and outcome may be poor. So what you have to do is, if it is hyperkalemia, usually it will be associated with severe acidosis. So in that case, you have to correct immediately hyperkalemia with insulin dextrose, calcium gluconate, and if in rare cases, you may need to start off with sodium bicarbonate. So when you are giving sodium bicarbonate, you have to establish the effective ventilation. That is very important. Otherwise, the sodium bicarbonate can create intracellular acidosis. So usually avoided in the normal situation. If there is a hyperkalemia, we are giving sodium bicarbonate. Calcium gluconate is the first drug we are giving. So it will stabilize the myocardium, and you have to give 10% calcium gluconate per 1 millimoles per liter per kg. So this is how you will deal with the hyperkalemia. And hypokalemia, you can, if you find the report, you can immediately correct the hypokalemia. And then sugar. So sugar is corrected with 10% dextrose, 2.5 ml per kg, immediate bolus, and followed by maintenance fluid. And then we will move on to the hypothermia. So hypothermia is another cause for cardiac arrest, so which can cause electrolyte imbalances, clotting derangements. All these things can create several pathways for arrest. So you have to immediately correct the hypothermia if the child is very cold. So drowning, sepsis in smaller babies can create hypothermic situation. So you have to start your external rewarming as well as internal rewarming. So external rewarming include your warming up the environment, removing the wet clothes, and wrap up with the towel. So all these things can be done. And internal rewarming, again, warm fluids you can administer through a warmer. So these will keep the child temperature up, and it will help to prevent the arrest, prolonged arrest. So these are the 4 H's need to be corrected in the cardiac arrest management, and the 4 T's. So when it comes to 4 T's, tension pneumothorax. So when tension pneumothorax is usually common reason following trauma, and maybe due to severe asthma. So in this case, you know that preload will be very low, cardiac output will be very low. Patient can go into pulseless electrical activity and then into asystole and arrest. So this is the common pathway for this type of arrest. So if you want to remove the tension pneumothorax, you should identify the patient whether he is having tension, signs of tension pneumothorax. So you can see the chest expansion. So if there is single-sided expansion, you may suspect tension pneumothorax. Mechanism of injury in trauma, whether there is a runover injury in the chest. So all these things will help you to identify underlying problem. And if you detect with a fast scan, then you can see the pleural movements. And if it is not there, you have to think about tension pneumothorax. And if you identify tension pneumothorax, immediate release is very important. So you have to put the needle in the second intercostal space, mid-clavicular line, that is needle thoracocentesis. So if the bubbling comes out or not, you have to proceed with the chest drain. So that is how you will deal with the tension pneumothorax. While dealing with this, you can give a fluid bolus in order to increase the preload. So that is how you have to involve with this tension pneumothorax. And the cardiac tamponade, very rare in children, but heart-related problems or following surgeries or following trauma, they can come out with this. But the signs are very difficult to detect, but fast scan will be a helpful sign. So you can do that and see if you are highly suspecting cardiac tamponade. So here also similar problem. There is fluid around the heart and it won't allow the heart to dilate. So the preload will be low and your cardiac output will be low. So you have to correct the cardiac output. Maybe you can give some fluid and aspiration through the cisternae area. So pericardiocentesis is very important in this situation, and you need to call for help in both instances. Then this toxic substance, you have to ask the history from mother, look for smells, any abnormal smells, pupillary reflex, how is the pupils are reflecting. So this is very important to identify the problem. So you have to ask from the mother, and think about drug addicts and NAIs. All these things are very important when you are dealing with this type of patients. Then thromboembolic phenomenon, so it is very rare in children. If you are suspecting, you have to treat that condition. So these 4Hs and 4Ts are very important while you are resuscitating the patient. So while you are doing the CPR, you have to search for these problems, and you have to immediately resuscitate if you have found any of these problems. So if you can able to detect one or two problem, and if you can able to correct it on time, the outcome will be very good. The cardiac arrest will reverse very easily. But if you take time to find out, and if you don't involve in any of these detection, then the arrest will prolong, and usually the outcome will be very poor, right? So all of you have to go through this things and take a 12-lead ECG, and again to recheck whether you have missed any 4Hs and 4Ts, and immediately correct all those things. If there is investigations left behind, bring back all the investigations and do the needful resuscitation, and maintain the temperature control while you are transferring the patient out of the unit to give a permanent care. Right, so this ends up the non-shockable rhythm algorithm, and we will move on to see the other rhythms. So when you see this rhythm, you can see a broad, complex, irregular, there is no waveforms, only Q waves. So you can take this as ventricular fibrillation, and this is very rare in children, but in some occasions they can have it, electrolyte imbalances, hypothermia. So all these conditions, they can have this type of arrest. And if you find out this rhythm, you may need to defibrillate, and you may need to stop the heart, and you may need to restart the heart. So defibrillation is the treatment for this type of rhythm. So when it comes pulseless VT is another rhythm form, so where we are giving defibrillation DC shock. So when it comes to this algorithm, again, if you take, it will go in 2 minutes time. So once you detect the rhythm, you will immediately give the DC shock. They are the cannulated, but here it is the DC shock we will give. So DC shock in any child is 4 joules per kg. So if the child is 10 kilos, you will give 40 joules in your monitor, and you will give it immediately. So once you give the shock, the myocardium goes into a stunting state. So you have to immediately restart the CPR. So this CPR should continue till 2 minutes. So while doing that CPR, you may need to prepare for the next cycle. So you have to get the IV access during that cycle. So you will get the IV access or IO access. After that, you will send for blood for investigation. And then you will prepare the adrenaline, which has to be given after the second shock. And you will be ready for the second cycle. So once the 2 minutes come up, you will stop the CPR and immediately reassess the rhythm. If the rhythm persists, you will deliver your second shock immediately. See, at the end of the second shock, you will give your first dose of adrenaline, that is same dose, 0.1 ml per kg, 1 in 10,000, with a normal saline flush, and restart the compression. And at the end of the 2 minutes, we will reassess the patient rhythm. And if the rhythm is same as VF, then you will give your third shock. And if you, after the third shock, you will go for the amiodarone 5 milligram per kg as a bolus. So continue the CPR. While continuing the CPR, you always go and check your 4Hs and 4Ts and find out the causes and try to resuscitate immediately. So if you do all these things, the rhythm might reappear. So at the end of the 2 minutes, you will stop and see the rhythm. If it is a sinus rhythm, you will check the pulse and stop the CPR and start to assess your ABC in order to give the post-resuscitation care. So in a shockable rhythm, you are giving shock, adrenaline, shock, amiodarone. So this is how the algorithm goes. And if the rhythm is persistently VF or VT, always call for pediatric cardiologist help or any cardiologist help. That is very important. And try to take a ECG, 12-lead ECG, and prepare again, go back and search for 4Hs and 4Ts. And if you can able to find out any causes, immediate correction is very important. Make sure that you are giving adequate ventilation for the patient. And temperature control is very important throughout the care and during the transport. So send the patient to a permanent care. So in defibrillation, any child, it is 4 joules per kg. There are pads as well as pedals. So we are using more in our country, most of the places, it is pedal. So there are pediatric pedals and adult pedals. Over 8 years, you can use the adult pedals, and below 8 years, you can use the pediatric pedals, go to your units and find out the cardiac monitor and try to see what are these things, because during the emergency, it's very hard to familiarize with the equipment. So beforehand, you should be able to familiar with all these equipments in the emergency area. Right. So during the resuscitation process, family members may be there. So they are the people worried about the child, more worried about the child. So if they want to visualize or if they want to stay and see the cardiac resuscitation going on, you can allow them to be there. But if they are disturbing your process, you can allow them to be seated in a different place. But make sure you are giving some help, and you have to go and tell the situation, what is going on with the patient then and there, and make sure that they are going through that period in a peaceful way. Otherwise, they will get a shock when you are breaking the bad news, right? So make sure one nursing staff will be there to look after the parents. So this is how you will resuscitate any cardiac arrest. So you have to always give priority for airway in children. So open up your airway and then make sure that breathing is happening. So ventilation breaths, and you have to make sure that ventilation going very well. And then you will go and assess the circulation and immediate resuscitation. And then you have to go and assess the disability at the end. So A, B, C, D is the approach even in cardiac arrest management. So that's the end of the lecture. Any questions?
Okay, thank you.
Now tea break can come to 10:35.
Right. I think we can start the session. Next lecture is by Dr. Michael Jans, consultant pediatrician at LRH. Over to you, sir.
Okay, thank you. Can you hear and see?
Yes, we can.
Okay. So I'm Dr. Michael Jans, consultant pediatrician. I'm a pediatrician at Balapiti Hospital, and the next lecture is going to be about a child with breathing difficulties. So when you start your internship in pediatrics, this will be probably the most common problem that you will have, a child with breathing difficulties. So we'll just go through a few cases that we will get and try and work out things. So in this lecture, we will try to go in a structured method. We'll try to So we'll try to take a structured approach. So always when you're managing ill patients, always try to go in a ABCD way. So ABCD method. So that will be very easy to assess and manage patients. And during this lecture, we'll try to describe the assessment and resuscitation of a child with life-threatening breathing difficulty and describe some of the key features that you will get with a child with breathing difficulties, as well as to describe a little bit of the emergency treatment. So in a child, children are different from adults. So they are more vulnerable and more likely to get ill very quickly. So it's very important to know this. So there are various reasons. One is that they are immunologically immature. So their immunity is immature. So they are very more likely to get very, very ill with diseases that might not cause that much problems in an adult. Their airway sizes are small, so even a slight obstruction will cause a relatively bigger obstruction in the airway, leading to airway collapses. And chest wall compliance is more because of more cartilaginous pliable chest walls, so they can easily have a lot of recessions and have a lot of distress, and their lungs can collapse very quickly. Small lungs and their volumes are less, so they can lungs can collapse quickly, and their respiratory muscles also can be weak, so they can get exhausted quickly. Smaller children, the control of breathing also might be less. They might be more acne. So because of this, if they have an illness, a respiratory problem, they can deteriorate very, very quickly. So it's very important when you're doing internship in pediatrics to detect a child who is deteriorating. So it's very important that you must know the normal respiratory rates, heart rates of a child. So, and also understand when there's increased work of breathing. So children, if they're having distress, you will see recessions. So you'll look for intercostal, subcostal recessions, look for signs of distress like grunting, nasal flaring. And like I said, you should know the normal rate. So look for increased respiratory rate. So when you are seeing patients, always count their rate, and you must know what the normal rate for the age is. So the smaller children, they have their rates are higher than the bigger children. Bigger children will be close to the adult rate. So when you're doing your internship, always have a chart with the respiratory rates initially, and look at that the chart and see if the respiratory rates are high. So the higher the respiratory rate from normal, the more ill the child is. But remember, the respiratory rate is less than normal and child is, it is very dangerous. So always look for the increased respiratory. So initially, child's respiratory rates will go up, and if they get exhausted, they might become apneic and respiratory rates might come down. So also look at the pulses. Like the respiratory rates, you must know the normal rates. So if the child is exhausted, fatigue, that is a very dangerous sign. Any alteration mental status is a very dangerous sign. So if you have a child with a respiratory pathology, their rates will go up slowly, their work of breathing will increase, their pulse rates will increase. When they can't compensate anymore, they'll become fatigued. They might have altered mental status. They get cyanosis. It's a very bad sign. That means they're about to collapse, right? So very important to detect these, if you detect these signs and take action quickly. So call your seniors, you have to take action quickly, otherwise child will arrest. So if you have a problem in respiration, you have to go again a structured manner. So it's airway breathing circuit. So if you have a child, first thing is to make sure the airway is patent. So I think in the basic life support, they have taught you the basic life support, they have told how to open a airway. So less than 1 year, the child should be in the neutral position. More than 1 year, sniffing position. So we will use airway maneuvers, head tilt, chin lift, or jaw thrust, and open the airways. If there are any secretions, clear out the secretion, open the airway. There's still distress, you might need some oxygen. So high flow oxygen, either through nasal prongs or through a mask. So if the child is not breathing properly despite this, then they might need ventilatory support. So you'll have to open the airway, maintain, give oxygen. If child is not breathing, just giving oxygen won't be enough. You might have to give ventilatory support. So you start maybe back and mask ventilation, and then get ready to take over the airway if the child is not breathing. So after SSN, depending how bad the child's, you will have to do different things. But always go in this order: open airway, high flow oxygen, ventilation. If you go in this order, you won't miss. So if you have a child with breathing difficulties in emergency, there are a few key features that will help you identify the cause of the breathing difficulty. So if you get the cause, so while you're managing airway breathing circulation, you can get a definite idea what the cause is. If you know the cause, you can treat the underlying pathology. So if you have a stridor, it's a feature of a upper airway obstruction, either a viral group or a epiglottitis or a foreign body or anaphylaxis. So stridor is, you'll get an idea what the pathology and what you need to do. If you have wheezing in a child, it's either bronchial asthma, it's a lower airway obstruction, so either bronchial asthma or a bronchiolitis. So less than 1 year bronchiolitis, more than 1 year, more likely to be asthma. So any child with respiratory distress, tachypnea and fever, always think of pneumonia. So from far away, when you can say, okay, suspect a pneumonia, high fever, ill child, tachypneic, respiratory distress, think of pneumonia. So remember, all children with respiratory distress are not having respiratory problems only, they might have cardiac problems. So always, if there are no lung signs or minimal lungs, look for features of heart disease, look for murmurs, look for features of heart failure. Take the history properly, right? So it's heart disease, no point treating the respiratory, you have to treat the heart problem. So even there are other causes of tachypnea, like example in poisons. There's a history of taking some substance, they might have acidosis, which result in tachypnea and respiratory distress. So take your history, make sure there's no poisoning. So if you have a urticaria, history of allergen ingestion, and respiratory distress, think of anaphylaxis and manage accordingly. So if you have a lot of secretion in the child, it could be a poor cough reflex. So you'll have to open out the airway and suck out secretions. There's a snoring sound, that's a bad sign. That is, if child is conscious level is low, and as you hear snoring sound, it could be the tongue is falling back. So then you have to open out the airway and might have to take over the airway. So those are bad sounds that you should look for. Stridor, of course, I mentioned some of the causes of stridor. So loud stridor and cough is more likely to be a viral group or a foreign body. A soft stridor, septic child, ill child, think of a tracheitis or epiglottitis. If you have a sudden onset cough and stridor in a previously well child, think of a foreign body. Right. So just a few, we'll just go through a few conditions where the children will present with breathing difficulties. So we'll start with some upper airway obstruction. So we talked about causes of stridor. Stridor is upper airway obstruction. So common thing that you might see is viral croup. So these children generally between 6 months and 5 years old, they have just initially that features of a cough and cold only. They might have a barking cough and they are relatively well and might have only mild fever initially, relatively well, but with time they might get worse and develop the barking cough might progress to a stridor. So these children generally not ill, but if it's a severe viral group, they might be very ill. as well and might have respiratory distress, low saturation. So if a child is present in like this prodromal trial cough cold for a few days, barking cough, and then develops a stridor and difficult breathing, increased work of breathing, and presence to you in the internship, first thing you must do is don't disturb them. So this is a upper airway obstruction. So if the child cries, the obstruction might get worse. So don't disturb the child. Call for help. Any upper airway obstruction is a emergency. It's a partial obstruction. It might go to complete obstruction. So if the child is in distress, give some oxygen. Right? So when you're giving oxygen, so don't go and push the child mask onto the child. Make sure that you don't disturb the child. Keep the child on the mother's lap. Keep the child comfortable. Don't allow to cry and allow the mother to hold the oxygen mask. So definitely, if you want to relieve the obstruction, you can nebulize with adrenaline. So we can use 1 in 1,000. Take a vial of adrenaline. You give 0.5 ml per kg of adrenaline to a maximum of 5 ml and nebulize with oxygen. Definite treatment is steroids, so you can give dexamethasone 150 micrograms per kg up to 600 micrograms per kg. So alternatively, you can give some nebulized butanacide. So if the dexamethasone is not working, you can repeat. So if not getting better, if child is in severe distress, call for help. So if it goes into a complete obstruction, the airway might need to be taken over by expert. But remember this, it's very rare to proceed this far. If you manage, don't disturb the child, give some oxygen, use adrenal nebulization and give steroids, the child should get better. But you have to always reassess and see if the child is getting better, go call for help. And like I said, don't try to reduce the upset to the child. Don't let the child cry. So the other condition they can present with stridor in this similar age group is epiglottitis. So the difference in epiglottitis from viral group is it's a shorter history. In the viral illnesses, the history is maybe 2-3 days. It will be a shorter history in epiglottitis. Child might have very high fever, very ill looking, toxic, maybe drowsy, may have drooling. And so this ill toxic child, it's a different presentation. So when you see the stride, you hear soft stridor and see ill child, think of epiglottitis. So the main thing in these things, mainly things you don't do. If you upset this child and the child starts crying more, this partial obstruction might lead to a complete obstruction and the child might erase. So don't upset the child. Don't go to examine the throat. So this is a picture of epiglottis, but don't go to look at. If you go to look at the throat, the child will erase. So main thing is to call for help quickly. So till help comes, if the child in distress, you can give some oxygen. So again, you keep the child in the most comfortable position so that it doesn't cry, and get the mother to hold the oxygen. You can try some nebulization with adrenaline, 0.5 ml per kg up to 5 ml, like in the viral group. So don't go to put cannulas in the ward unless you have some pain relief. So most this sort of say you have to call for help. So in this place, the help will be the people who can take over the airway. So the anesthetist or the intensivist or the ENT surgeon. And this child will have to take this child to the theater, and the anesthetist will have to give a gas induction and take over the airway and secure the airway. After securing the airway, they will put IV cannula and take blood cultures and start IV digestion cephalosporins for the epiglottitis. So main thing is don't upset the child, call for help, give some oxygen, make sure that this child is safe. So next one is a bacterial tracheitis. It's a similar presentation as the other one. Generally, in the epiglottitis, you don't have much of a cough, but you'll have a cough in the bacterial tracheitis. But again, it will be ill toxic child with a soft stridor. So again, same as the epiglottitis, call for help, don't upset the child, might give some oxygen. You will have to take to the theater and anesthetist will take over the airway, and after taking over the airway, to start antibiotics. So in the epiglottitis, generally H influences the organism. So we give third generation cephalosporins. In bacterial tracheitis, it will generally be a Staph aureus. So we'll have in tracheitis, it will be a Staph cover, either fluclox or vancomycin. So the other upper airway obstruction that can present with stridor or is foreign body. So foreign body, it may be a witnessed foreign body. It may be in outside the hospital. So in the basic life support, they would have taught you about the choking child, how to manage. So if it's a conscious child with the effective cough, allow them to cough. If there's an ineffective cough and child is conscious, 5 back blows, 5 chest thrusts, and continue. If any visible foreign body, remove. If the child is unconscious, you will have to start BLS. But every time before you take a breath, you have to open and see if there's any visible foreign body to remove. So it's very important to do the choking child algorithm if you are outside the hospital. If there's a complete obstruction, they might come, you might, while giving BLS, you might have to relieve the obstruction, either with direct laryngoscopy or cricotyretic when they are in the hospital setup. So you will need help in these children. You will have to call the ENT surgeon and anesthetist to take over the airway. So they child might need laryngoscopy or bronchoscopy under anesthesia once you have managed the acute problem. So going down, so the early conditions we were talking about, breathing difficulties in the upper airway. The lower airway in children, there are 2 main causes of breathing difficulty. And lower airway, you will have wheezing. So asthma and bronchiolitis. So if a child comes with wheezing, less than 1 year, most likely it will be a bronchiolitis. More than 1 year, it's most likely to be asthma. So so I won't be talking about management of acute asthma. There will be a separate lecture for asthma because it is a very important topic. So we'll be giving that lecture as a separate one. We'll just be talking about bronchiolitis. So bronchiolitis is caused by a virus, respiratory syncytial virus, and like all other virus, like viral disease, it is a prodromal period. About 3-4 days, it will just be like an upper respiratory tract infection. By about the 4th day, the child will become tachypneic and will have lung signs, Krebs and bronchi, and might have low saturations. So if it's a very mild bronchiolitis, it will get better on its own without you doing anything. But if the child has low saturations, we'll need some treatment. So generally, it's less than in 1 year. And in cold countries, it's seasonal. In our country, we get it all year round, but more during the rainy season. So it's due to a respiratory syncytial virus mainly, but the other virus can cause it as well. And like we mentioned, characteristics, there'll be cough, wheezing, might be some breaths. And initially, the child might be normal, but might have worsening respiratory distress, might have apneas, especially in smaller children, in the neonates. So it's very important to know a few things on which sort of child will be more affected by bronchiolitis. So the smaller the child, the more worried you are. So if you have a child who's 1 year and a child who's less than 1, with bronchiolitis, you're worried about the younger child. The more immature the child, the more likely to have problems. So you have to be very careful with the smaller baby, especially if there are preterm or ex-preterm babies. And a good idea of how ill the child is the ability to feed. So if you ask the mother and say feeding is poor, you have to be worried and look after that child very carefully in bronchitis. And always check the saturation. So if the saturation in air is less than 94, we'll need oxygen support. If there's any underlying cardiac or respiratory, again, you have to be worried because these children with underlying cardiac respiratories are more likely to have a more severe and prolonged course of bronchiolitis. And I mentioned about prematurity. Prematurity are more likely to be affected badly. So these, if you have any of these in the history, these should be red flags, and you should monitor those child carefully and take intervention quickly if there is any deterioration. So monitoring is the most important. Like I mentioned, look for the respiratory rates where they are going up, the work of breathing saturations. So these children, they have a lot of secretions. Their airways may be upper airway may be blocked, and especially smaller children, when their nose is blocked, they don't know how to breathe through their mouth. So you have to clear the airway. You have to open the airway. And bronchiolitis, the main treatment is oxygen. So by about day 3, day 4, they need some oxygen, need some support. If you support them, the bronchiolitis, when the body clears the infection, they will get better on their own. So your goal is to give some support till they get better. So main treatment is oxygen. So there are various ways of giving oxygen. So in smaller children generally will give through nasal prongs. So remember, you can give only a maximum of 2 liters per minute with the nasal prong. If you want to give more oxygen, you'll have to use a mask. And there are other ways of giving, for example, humidified high flow oxygen. So if your oxygen by mask or nasal prongs is not working, you might have to use what is called a high flow machine, which gives heated high flow oxygen, in which you can give a higher concentrated oxygen. And always remember to maintain the nutrition and hydration of the child. So you have to monitor these bronchiolitis patients very careful. So if their respirates are going higher and higher and that's not getting better, and you stepped up your treatment, and if it's still not getting better, and if they start getting apneic or getting exhausted, you may have to go for elective ventilation. So you have to monitor very carefully. This is more so in the smaller children and preterm babies. They can become apneic and may require ventilation. So general bronchiolitis, you don't do much investigations. So it's a clinical diagnosis. There's very little use in chest X-ray unless you're suspecting a pneumonia or if it's a very severe illness. And generally, it's just oxygen. Unless you have secondary infection, you won't give antibiotics. There's no proven benefit of nebulization or steroids. So mainly oxygenation. So this is an X-ray of a child who is presented with fever, cough and cold, and difficulty in breathing and tachypneic. So if you have a child who's tachypneic with high fever, till proven otherwise, it's a pneumonia. So if you auscultate, you might get some bronchial breathing, reduced entry, and this is a lobar pneumonia. So if you have a child with the pneumonia, obviously with focal sign, you'll do a chest X-ray. You might need to do ultrasounds if there are suspected effusions. So basically, pneumonia, again, they're in distress. You have to give oxygen. If their saturations are low, give oxygen. So oxygen, like in the bronchiolitis, you might start with nasal prongs or mask. If it's not working, you might have to use heated, humidified, high flow oxygenation or CPAP. So lot of the bad pneumonias are bacterial. So you'll have to take blood cultures, count CRP, and start some antibiotics. So depending on the cause, what antibiotics you give will be different. So if you have huge effusions, you might need drainage. So it's very important that you monitor these patients and see. So we are giving oxygenation. If they're not getting better, if they're getting tachypneic and then become apneic, don't let them rest in the ward. You might have to call for help. They need their airways to be taken away electively. So all causes of breathing difficulties are not respiratory. You might have heart conditions as well. So you might have large shunts, VSDs leading to heart failure. There may be left heart obstructions like aortic stenosis or coarctation of the aorta. You might have pump failures with myocarditis. You might have dysrhythmia. So any child with breathing difficulty, don't assume it's a respiratory. You have to take a thorough history and examine. Look for murmurs, see the cardiac size, see the full cardiovascular examinations well, make sure it's not a cardiac cause. And so some key things in, if you have a cardiac cause, you might have enlarged heart, you might have a hepatomegaly. Look for tachycardias, gallop rhythm, look for basal crepitations, look for cyanosis. And once you have done the clinical things, you will obviously do X-ray, and you can see in this X-ray, you might have cardiacally, you might have vascular congestion. So heart failure, main initial treatment, oxygen and diuretics, and you'll have to do the chest X-ray, ECG, and echo and see the definite diagnosis, and you might have to modify your treatment after that. So, okay. So, yeah. So someone had asked some questions. If you have any questions, you can type in the box. I think there were some questions. I'll just have a look. Yeah. Any questions you can type in the box and can try and answer. Okay, so if there are no questions, we will conclude the session. So remember, in a child with breathing difficulties, do your primary assessment and resuscitate. Look for the key features like stride or wheeze, fever, heart failure, and do the appropriate emergency management. So thank you.
Right. Thank you very much, sir. We'll go to the next lecture by Dr. Krishant Dalpadatu, pediatric neurologist at PGH Kurunegala. Illness and disability and convulsions on the theme. Right. Over to you, sir. There's a small change in the lecture. So now lecture will be done by Dr. Amali Dalpadatu on transportation of sick child, consultant pediatrician at KDU Colombo. So over to you, madam.
Can you all hear me? Hello?
Yes, we can hear you.
Hmm? Can you all hear me?
Yes, we can hear you. And we can see you too, yes.
Hello? Can you all hear me?
Yes, we can see, we can hear and see you, Dr. Amali.
Chamodi, can you hear me?
Yes, madam. Yes.
All right, okay. Right, so today we are going to talk about stabilization and transfer, which is one of the most important steps. Probably if you are working outside Colombo, will be exposed to a lot of this type of activities or stabilization. You will be taking part in a lot of transferring of patients as a junior doctor. Now, if I just ask you a question, Chamodi has strictly told me I can only take exactly 30 minutes, so I have to sort of just take a few minutes of to understand what your understanding is. According to you, who should be the person involved in the transfer, deciding on the transfer of a patient? Will it be the house officer? You will be becoming house officers, and there will be some senior doctors and a consultant, hopefully. And if there's no probably if you are working as intern house officer, you will be working in a center where a consultant is. So who should be taking the decision to decide on a transferring of a patient? Yes? Anybody? All logged in and not physically there, or anybody who's there listening to us? You can unmute your mic and talk. You can even put on chat if you want. Okay, somebody says there's no black and white answer. It depends on the condition. SHO, okay. So probably I would say the transfer, the most senior person at the premises. Yes, so at the premises, but there would be an on-call consultant, even though that person is physically not there. I would say the consultant would decide on the transfer. The director of the hospital will decide on more admin issues rather than a transfer of a patient. So the transfer should be decided by the on-call consultant. If since you all will be working in a hospital where a consultant is, appointed, right? So it's very important that you know that. And the house officers and the SHOs can't suddenly transfer a patient. So why do we need to transfer patients? It's very important to know. And so I'm Dr. Amali Dalpatadu. I'm consultant pediatrician, a senior lecturer working at the University of KDU. Some of you may know me who are from KDU, and some of you may have met me at APLS. But it's up to where you are going to transfer, why you are going to transfer. Certain questions needs to be looked into before you're transferring a patient. So in completing this workshop, you should be able to refer a sick child for a definitive or a specialized care. So sometimes you don't have the facilities, and then you need to escalate the care and plan and help to ensure the safe and successful transfer of a sick child between the units. Right? So transfer not be necessarily to another hospital. It may be to another unit even. So evaluation of the risk versus benefit. So what is the indication for transfer? Now, simply because a patient is bad and very sickly, now patient arrested on your hands, are you simply going to transfer that patient? Are you going to transfer a dead body to a neighboring hospital? So what are you going to do before transfer? So indication. So are you going to, so if you're simply going to get some opinion, say neurosurgical patient, you're going to transfer to a center where there's no neurosurgical help available. So you have to think, right? And where you're going to transfer, and how long is the transfer going to take? Say, especially you're working in a center like now I worked in Anuradhapura, and usually if you're going to Colombo, it takes 4 hours. Even in an ambulance, if they really ring the siren and go through, still 3.5 to 3 hours. The environment, right? And your skills and the patient's condition. So the patient condition, will the patient survive 3 hours? If they are coming from Jaffna, it's going to take more, right? So say 4 to 6 hours probably. So 6 hours, they're coming from Vaunia, it's going to take more. It's coming from Batiklo and Nuarelia. So the geography is so difficult, it might take more time. So where are you going to transfer, how long it's going to take, and the environment and the skills and the patient condition all matters. And you need specialist treatment, especially you're a general pediatrician, general physician. I mean, we are talking about children here. So we are looking at getting some specialist opinion, intensivist opinion, cardiologist opinion, child with a duct-dependent circulation, or a child with a special neurological problem who needs support, or an endocrine problem where you need a support of a specialist treatment, or respiratory support or ICU care. Most of the time, why we transfer is for ICU care or critically ill patients. So how critically ill is the patient? Is the patient going to survive your journey, and who's going to do it, and how you're going to do it? Is what we are going to discuss. So sometimes you may refer a patient simply because you don't have a particular investigation. Say, for an example, you have a child with ambiguous genitalia who are they 6-7 of age, and you don't know it's a congenital adrenal hyperplasia or not. So you may need that type of patients, but those children are not acutely ill, and you need a cardiac echo done in a child who is cyanotic and who is having slightly low saturations and a pre and post ductal saturation difference. So therefore, you might transfer this type of patients as well. So where are you going to transfer? It may be within the hospital. So say, for an example, you got a patient who might need a CT scan, who is in the ICU, who is critically ill. And that transfer to the CT to and fro will, need some pre-planning. If the patient is already ventilated, this patient is intubated, you might need support. And inter-hospital, the most common thing that we talk about, inter-hospital transfer. Therefore, inter-hospital transfer, we need a support of the receiving end and the referring end. And the connection is what you're transferring, vehicle and the people and the equipment, right? And international transfer, we don't do many international transfers, but sometimes in the private sector, they do international transfers, right? So then, what are the problems in transferring of a patient? Think about your patient. What are the problems you're going to anticipate in this child? So we have to have some sort of an agreed plan. You need to think of transferring. Say, for an example, you're coming from, say, Batikalo. You should have a destination. It could be either Kandy or Colombo. No, you should have a proper destination where so where are you going to transfer this patient? Say you are going to send the patient to LRH. Are you going to send the patient to Kandy General Hospital? Are you going to send the patient to Sirimao Bandaranayaka Hospital? Or is it Jaffna or Anuradhapura? So you have to decide your destination. If you're sending the patient from Vaunia towards Jaffna, you have to think whether what you're going to achieve is available in Jaffna. So it doesn't have to be always Colombo or Ledridgeway Hospital or, suburbs of Colombo. Say you're coming from Pomagama, you're looking for ICU bed, the bed is available in Gaul, patient should go to Gaul. And destination department, whether it's an intensive care unit, whether it's a cardiology unit, whether it's a general pediatrics unit, and whether the bed is available. This is very important in ICU. You can't simply pack up the patient and, just go. Even in transfers in other countries, in transfers for normal ward patients, you can't just simply send a critically ill patient without talking to the receiving end. And the accepting doctor, accepting consultant should have accepted the patient. You can't simply send a patient to an ICU, say you have to take over this patient. Now we have sent. They have to accept, right? And they have to if they have a bed, they should be accepting it. So it's a two-way process. And what is the mode of transport? Are you going to send the patient in a tuk? Is it an ambulance? Or do you have a van, whatever? So most probably appropriate is your ambulance, right? So staff involved in the transport, who is going to send the transfer? Most of the time, as house officers, you will be asked to accompany the patient alone, right? And you have to consider, so am I able to do or troubleshoot this patient if the patient deteriorates on the way? So estimated time to readiness for the transport. So how long it will take you to prepare the child for the transport, and the time of arrival at the receiving hospital. So usually they say, we will prepare the bed and let you know. And then until they inform you, you have to prepare the patient for the transfer. So IS bar. So IS bar is identify the referring hospital. Where are you going to send the patient? Say you are going to send the patient to Sirimao Bandaranayaka Children's Hospital. You are going to send from Mahawaya, or you are going to send from Navalapitiya. Gampola Navalapitiya is not too far away. Say you are going to send from Ampara, right? And you are going to send to Sirimao Bandaranayaka for a ICU care. Whom are you referring to? So probably the intensivist on call or the consultant pediatrician who's looking after the intensive care unit. And the receiving hospital, who's the receiving doctor, that is the junior doctor or the middle grade doctor who is there. You have to contact that person. Even though you have contacted the consultant, you have to contact the on-site doctor as well. And the contact phone number of the on-site person or the consultant. So the contact number should be with the people who are contacting them from the sending end, as well as the person who is going on the transfer. So you have to identify the patient, the name, the date of birth, and the age and the weight, all should be clearly documented. And what is the problem? Why are you transferring? Are you simply transferring because you want to, go and probably you are having an off weekend? No. So why the reason? Is it to escalation of care? Is it to get some respiratory support? Are you referring to get some high flow? Are you requiring a ventilator? Are you requiring, because the patient's conscious level is reduced, you might think that the patient might need ventilation or respiratory support or need some high neuro investigations, and what you need from the list, right? So you have to tell them, we need these support. Say the patient is a trauma patient and you might need some blood. And what have you done? I have given a bolus, I have intubated the patient, and we are bagging the patient, and we have given some antibiotics, and we have given some sort of medication to stop bleeding, like tranexamic acid, etc. And effects of these actions. So you have given a bolus. After the bolus, the circulation is improved. And summarize the agreed plan. So you have to say, okay, we are planning to do this. And that is a summary. Equipment. So what are the equipment that you need to take? So do you need some respiratory support, proper airway equipment, breathing equipment, circulation, the cannulae? So if the patient is intubated, do you not need another tube? Yes, because you're going on a transport and the tube might come off and you might need another tube. You might need a working laryngoscope. Most often people realize when the tube comes off, the laryngoscope they have taken is not working. The batteries are not functioning. So you have to make sure the batteries are functioning, laryngoscope is functioning, and backup for vital equipment. So you should have a backup of mask, backup of a bag, and even a laryngoscope if possible. How does it work? How does the equipment work? You have to be familiar with the equipment that you are taking. So what are the drugs that you need? You might need adrenaline, life-saving drugs. Sometimes you might need drawn, but sometimes you might take just a vial and the syringe as the nurse is competent enough to do it on her own. Or you can have a standby, right? If the nurse is competent, she can draw, then you can say. If you're taking a patient who is developing seizures, you might need seizure medication. If you have given 2 doses of benzodiazepines already, like you have given your 2 doses of midazolam, you might need your phenytoin or phenobarbital or levetiracetam if you have it available. So you might make sure that you have to have those drugs. And if you're thinking of a reduced GCS, you might have to take your 3% saline. Stock. So, if you just take 1 vial of midazolam and it falls on the ground and it breaks, then you don't have another vial of midazolam if the patient develops a seizure. So that's going to be a disaster. So 1 vial of adrenaline and it falls on the ground because the ambulance is, jerking, and the suddenly it breaks and the vial goes off the nurse's hand and it falls on the ground and it breaks. That's it, right? So it shouldn't be the case. You should have a backup. Documentation. So notes of the patient should be taken, referral letters and admission notes and rest of the things should be taken, and you should properly hand over and then bring them back to your place. But X-rays, we need to hand over to the receiving end. Investigations which were done, which you need to keep with the BHT at the referring hospital. At the referring hospital, you might have to take copies of, and the consent form should be properly signed off. So think about the oxygen, the mask, self-inflating bag valve, the resuscitator, suction equipment. Most often, the suction equipment is not working. There are nice hand operated or foot operated manual suction apparatus which you can use on transfer. Nowadays, most of the ambulances are geared with battery and they have the inbuilt plugs where you can plug in the electronic suction apparatus. But if you don't have those, you should have a manual suction apparatus which you can use. And even the oxygen, if you don't have proper stock of oxygen, say you're going at a 15 liters per minute oxygen, and how long will it take for the oxygen to finish? You have to make sure that you have enough stocks and enough cylinders of oxygen prepared for your journey. Right? You have to calculate. Say you have 50 liters of oxygen left in your cylinder and you're going at a rate of 10 liters per minute or 10 liters per hour, or then suddenly you realize your oxygen is over and the patient starts deteriorating and the patient starts desaturating. Okay? So you have to make sure, are you able to open the another cylinder? Is the attendant or the midwife or the nursing officer going there can open the oxygen cylinder, right? So the oxygen cylinder you're taking as backup, is the regulator working, right? And if there's enough oxygen inside, so you have to open it and see whether there's oxygen and whether it's a regulator is working. And you might take an entitled CO2 or a proper pulse oximeter is needed, and the pulse oximeter is properly fixed, and the pulse oximeter should have backup battery. So it should be, all of these should be charged previously and there is no battery backup, then you have to take something which you can plug in, but of course, most of the time it might go off, right? And sometimes if you have intubated the patient, you might need something like atracurium or some even short acting. Probably for a journey over 30 minutes, you might need a muscle relaxant, which will take you through the journey. And some probably you might need some induction agents also. That's what we have mentioned propofol. So before departure and assessment, you have to make sure what is happening with the respiration. Is the patient breathing on air, face mask, nasal prongs, nebulized, NG, C-spine protection is there, bag well mask is there, oral intubation and ventilation, nasal intubation and ventilation, whether you have extra ET tubes and the lip level of the ET tubes. Chest x-ray with the tip of the ET if possible. If you don't have x-rays in the referring hospital, you can't do that. If you have a blood gas machine available, you can do the blood gas. And the last gas which you have done, you should take it with you with the documentation. And circulation, pulse rate, and the volume, and the capillary fill time, and the blood pressure, mean arterial pressure, and looking at the perfusion. Whether the patient is in shock, whether it's compensated or decompensated. So compensated shock is the blood pressure is reserved, and uncompensated is you don't have the blood pressure reserved and the blood pressure is also low. So do you have a proper intravenous access? You need at least proper 2 IV access, and those should be secured, especially with the brake and the ambulance is going very fast. You might do IV access. And fluid boluses, inotropes infusions. Inotrope infusions, the infusion pump should have a battery backup. Whether the patient has been given chest compressions, whether the patient is on a catheter, whether the antiemetics given to the staff, right? The doctor, the nurse, the mother, and the GCS level. Whether the patient is totally unresponsive or what was the status of the GCS on transfer. And posturing of the patient on transfer. And even you have to document what was the condition on arrival at the receiving end. And the pupils, reactions, RBS. Are you on a 10% dextrose? So your patient was hypoglycemic initially. You have given a bolus. Have you put the patient on a maintenance strip of dextrose? What's the temperature? Whether there's rashes, protective measures have been carried out or not. So all these are very important. The personnel should have clearly defined roles and they should be adequately trained. Even though we do just transfers, people just go on transfers, may I know second on call, you go, something like that. In other countries, to go on a transfer, even intra-hospital, you should have a train. There are transfer retrieval teams. Neonatal, there are retrieval teams. There is NEST, various names are there. So there is a Southwest neonatal retrieval team. There's Oxford retrieval team. There's a London retrieval. There are various retrieval teams in the countries, but they are adequately trained for the transfer, especially the neonatal transfers. It's very important. At least get some training from your senior colleagues while you're doing your normal job, because you should not go your first transfer without having any proper idea as to what to expect. And if the tube comes out, what to do. I mean, not everything could be taught. You would be asked, you would be required to go on a transfer, but it's your duty as well to learn on the job how to anticipate, how to manage any expected issues. So communication. So how will you get help if you need it? So whom to call? The ambulance tire goes off, ambulance meets with an accident, whom to call, right? And the patient is in your hands. And you have to get the number of your referring doctor, receiving end, and then anybody who's nearby whom you would need some support from. So patient's condition, according to the airway, breathing, circulation, disability, exposure, and everything you have to look at, right? And physiological reserve of the patient. So usually children have a low physiological reserve and the therapeutic reserve. So this may be very low in the patient you are going to transfer. And the organ support of the patient organ support of the patient is also very important. Okay, and the final check of ABCDEF, blood gas, and the chest X-ray to check the ET tube position. So now you have the patient in your hand. You look at the patient's current status and the final check and care during the transfer. You have to observe your pulse oximetry, saturation monitoring, pulse rate and the heart rate, blood pressure monitoring, and you have to set the alarm limits. You should not switch off the alarms because it's so noisy. So factors affecting the mode of transport, nature of the illness of the patient, urgency of the transport, mobilization of time, geographical factors. We were talking about Nuvarali and how difficult it is. And of course, the traffic in Colombo, the weather, if it's raining and it's flooded, traffic conditions, and the cost. Are we doing a cost-effective transfer? Minimize the time outside the ICU. So departure time, expected arrival time, you have to plan properly. So you have to inform them, we would be arriving by this time. Usually ICUs are not closed for lunch, but still you should make sure the bed is prepared by the time you receive the end. And they should be prepared to receive your patient. And the handover, you should not run away giving the patient, we brought the patient, we are going off, transfer the patient, receiving, and you have to give the investigations, you have to tell about the procedures, you have to tell about the patient's status, stability of the patient, resuscitate the patient if necessary, and comprehensive handover at the receiving team when stable. Equipment check, you have to check the battery, oxygen cylinders, AED, external defibrillator, ventilators, suction machines, all the samples are there, whether you have the saline boluses, drug infusions, sedatives, and paralytic agents. Check on documents, whether you have got everything with you, letter to the consultant, observation charts, and you have informed the departure time, the expected arrival time to the receiving end, during the transfer, respiratory arrest, cardiac arrest, chest compressions, any AED used, boluses given, any drugs being used, re-intubations, bag and mask ventilations, contacted the consultants, or the patient died on the way. So to take the patient to MO admission, ETU direct to the NICU PQ, ideally directly to the NICU PQ. So you have to make sure you have to plan before leaving how to take the patient. So summary, you have to consider the risk versus benefit of taking the patient, careful planning, proactive planning. There's a lot to remember. Use the checklist. Additions as necessary. So most often, all the best with your transport. This is a transport acute accident where the child had met with a road traffic accident and the ambulance has arrived on the scene and they're going to take this patient to the hospital. So the patient needs definitely cervical spine stabilization. So here we are talking about a patient, somebody's child, somebody's, sibling who is depending on your care during the transfer, who is critically ill, who needs support. So therefore, don't compromise the care of the patient during transfer. I don't think we have time for this. Chamodi, would you be able to give me just 2 minutes?
Okay, madam.
So it's a regional emergency department. There's a RTA and the child had a left-sided head injury with the large contusion of the lateral aspect of the left thigh. Patient is unconscious on scene. So there's a head injury, lateral contusion of the left thigh, probably arterial damage and a bleed. So patient might be in shock. Patient might be needing CNS support. Patient is unconscious. GCS is 10. It's reducing. Heart rate is high. Blood pressure is kind of normal. So you're ventilating the patient with a cannula, with a saline maintenance dose. And the midazolam is being given. There's an unequal pupil, CT scan with an extradural hematoma. Child now needs ongoing care. So where would you transfer this patient? The patient comes to the regional emergency department. You need to transfer to a facility where you can do a borehole. If you can't do a borehole in the regional ED, you have to take to a place where they can do an emergency borehole and give a neurosurgical support to this patient. Otherwise, the patient's going to cone and die. At the moment, the heart rate is fine, blood pressure is fine, but the patient's going to get worse. GCS is dropping. So you have to adhere to the neuroprotective measurements as well. Okay. So this is that patient. You are going to protect the cervical spine. You have to stop the bleeding. You have to anticipate shock in this patient because there's a contusion of the thigh. There may be femoral damage, arterial damage, you don't know. And the patient has had a significant head injury. Right. Okay. So this is how you transfer. Relatives want to discussion. No consent on the phone. Okay, so these are the problems that we are going to anticipate. This is an actual live session that we would do. If you have time, we can do this as a sort of a live session, end of the day or whatever you have time. We can do this as a live session. Any questions based on what we discussed? Because I'm taking somebody else's time. Any questions? Who chooses which doctor, HO or SHO, is accompanying the patient in the ambulance? And can a family member go inside the ambulance? It depends, actually, as you said, because usually depends on the patient's illness state of, if the patient is intubated and ventilated, probably a middle grade doctor should go. But that doesn't mean the house officer should not go. She or he might need a support of a house officer as well. So if the middle grade is going, sometimes they might need a support of the house officer to get the drugs, can get the calls and rest of the things. And you are ambu ventilating, especially you don't have a transport ventilator, you might need another extra pair of hands. Usually we do not allow any relatives in the ambulance because there's no hardly any space, because there's a linear place where you can sit and the attendant sits on the other front seat. So there's hardly any space. So we usually allow only the mother because due to lack of space. So any issues, I think you can get my email from Chamodi. You can send what is the procedure if the patient died on the way. So the patient died on the way. Yeah, there are, if the patient gets arrested and you're trying to resuscitate, that is a situation. You don't wait until the patient dies on the road. You say you're going to, now you're going from Anuradhapura to you're going to Candice. So on the way, there will be some hospitals. Say the closest hospital you go to is Nikavarattiya, or you can go to, you can some off track, you go to Kurunagala. Kurunagala might be a little difficult. So you can go to Dambulla hospital. Whichever the hospital is closest to your destination, you take the patient. Even if it's a district hospital, doesn't matter. You take the patient to the closest hospital. You can Google up and see what are the closest hospital which is available and go to that hospital, continue the resuscitation. If still the patient passes away, you cannot resuscitate the patient, then you have to go through the same procedure as the patient died in that particular hospital. Okay. Right. Okay. Thank you very much. I think you are having the unconscious child as your next lecture. So your summary, you should now be able to refer a sick child for a definitive specialist care, plan to help and ensure a safe and a successful transfer of a sick child between units, and all the best with your all transfers. I'm sure most of you will be taking part in more than one transfer during your internship. Okay, thank you.
Right. Can somebody confirm that you can hear me and see the screen? You can hear, no? Can somebody speak from the other end so that I know that I can interact? Can somebody speak from that end? Chamodi, are you there?
Yes, sir.
All right.
Can
Okay.
hear. Okay.
Right. Now, I'm sure most of you will be uh, doing, at least 50% of you will be doing pediatrics and will come across. If you do pediatrics, will come across a child who is seriously ill. And the purpose of this lecture is to give you some insight into what competencies you need to gather during your internship, so that when you are posted to another station when you need to work by yourself, you can appropriately make decisions. Now, I am tasked with the two sections. One is assessing a child who is unconscious, and the second task is managing a child who has a prolonged convulsion. Both of these conditions are very, very common, and an unconscious child, a seriously ill unconscious child, is a nightmare to manage. I'm sure all of you will agree. This is because of lot of things. One is, on the one side, you have a very agitated mother and a father who had a child who was playing, speaking, crying, doing everything normally few hours back, and is now not speaking, not talking, either having a convulsion. They are worried whether this child will die, and they are asking you to quickly revive this child. Then you have another set of people around you, nursing staff, minor staff, other doctors. Everybody is also worried of what will happen. Will this child die? What will happen? Will this child, what will be the medical legal consequences if you can't revive this child? So lots of things are going through everybody's mind, and everybody is excited. Everybody is either worried. Everybody is uh, uh, in a very sort of a very anxious state. Then add to that, you have all the other mothers in the ward crowding around you, trying to see what is happening. So you can imagine, I'm trying to make imaginary picture of what it will be like inside either the OPD or the ward admission area at that point. So you need to be calm. You need to know what to do. You need to have a systematic approach to rationally manage this child and make quick decisions on what to do. So to do that in APLS, we use this systematic approach called the ABCD approach. When you see a child who's unconscious, we don't rush and manage the neurological aspects of it first. So we try to think what will kill this child first. So in any seriously ill child, an airway obstruction and a breathing issue related to the respiratory system is the one that will be detrimental first. Then comes a cardiac failure or circulatory failure. Those two things have to be assessed and properly stabilized before you go on to managing what is called a central neurological failure, which is what is our focus today. Now, when this is a busy slide, when it comes to neurological problems, people are scared. There's something called neurophobia. People don't like neurology very much and think that it is quite hard. But really speaking, it's a logical approach to identifying a few salient points that will tell you what is happening inside this child's brain. So first and foremost, you will have to identify what the conscious level of this child is. When you say conscious level, there are several assessments that you can do. The secondly, you have to look at the child's eyes, what is called assessment of the pupils. Then you need to look at the arms and the legs, looking at the posture of this child. If you just do these three things in quick succession, you are likely to gain a lot of information with regard to what's happening inside this child's brain. Is it failing? Is it coning? Is it swelling up? Etc. etc. And maybe also, as I will show a little later on, what the exact pathology is that has occurred inside the brain. Now, if you look at this case, here is a 7-year-old child, very listless. His eyes are opening to verbal stimuli. His motor response is to pain, and he's saying disoriented but conversive words. So when you come across a child who's unconscious or semi-conscious or reduced conscious level, you need to have a quick assessment that will take you not more than few seconds. So one way to do that is what is called this ABPU scale. So the ABPU scale, just you need 4 things to see. Is the child alert? Is the child responding to voice? Is the child responding to pain? Is the child unresponsive? Now, if the child is alert, there's no need. Child is probably not having any brain abnormality. But if beyond that, responding to voice or responding to pain is a very important demarcation. If the child is responding to pain and not responding to voice, that means his airway is unprotected and you need to protect his airway. If the child is unresponsive, then that is some that you can infer something very serious is happening. Okay, so now this assessment can be even done by a nurse. So when it comes to the Glasgow Coma scale in pediatrics, we use what is called a pediatric modified Glasgow Coma scale. This is a slightly extensive scale. So in the ABPU scale, it gives you a rough idea what's happening. It is a very crude assessment. You cannot assess subtle abnormalities or subtle deteriorations, subtle changes in conscious level by using the ABPU scale. So to do this, you need the modified Glasgow Coma scale. I'm sure all of you during our medical school days know about this. It has 3 main sections, and each eye of opening, motor response, and verbal response. Each of these components are divided into subsections. and each subsection is given a scoring. You can get a maximum of 15, or you can get a minimum of 3, and in between, there is if you have a less score of less than 15, that means you are having a child who is having impaired conscious level. And here again, 8 is the cutoff to say that the child needs airway protection. So if we take this child is responding to voice. So his I response to verbal stimuli means he's E is 3. M is withdraws to pain means 4. Verbal response is disoriented at conversion means he's confused, that is 4. Altogether, total, you get a total score of 11. Now, when somebody asks you what is the Glasgow Coma Scale, what is the GCS of this child, we tend to say his GCS is around 8 or 9 or 12 or whatever. Or some people say his GCS is 9 to 12. Now, you don't do that mistake. Now, if you look at the GCS chart, you can give an exact score. So there is no saying GCS is around this much or GCS is from this to this. At that point of time, GCS should be an exact number. And please remember, when you convey GCS to your colleague or your senior colleague or your, say, a colleague from neurology, try to say the breakdown. Eye opening is this much, motor response is this much, verbal response is this much, and the total score is this. So, like I said, E3, M4, V3, and the total score is 10, something like that. So, don't use ambiguous or what is called very vague ways to communicate GCS to your colleagues. Right. Now, the second thing is looking at what is called the eyes. Now, I'm sure all of you have heard this idiom in English, which says eyes are the window to your soul. Now, the person who said that actually had meant that the pupils are the window to your brain. That means looking at the pupil, you can tell what is happening in that person's whatever pathology is happening inside the brain. How can you do that? So there are 3 patterns you need to remember. So when you look at the pupils, you look at the size of the pupil, the shape of the pupil, the symmetry of the pupil, and the reaction to the light. And then you come to a conclusion whether one side is dilated, whether both sides are dilated, or whether the pupil is reacting to light. So it can be either small pinpoint reactive pupils, unilaterally dilated pupils, or bilaterally fixed dilated pupils. And all the conditions that you see, most of the conditions or all of the conditions can be grouped into either of any one of these 3 conditions. So you can either, so we given this in color codes: yellow, purple, or pink, or blue. So any of these can be, you can divide into, or you can identify a pattern in all these. There are, I think, 11 conditions here. The 11 conditions you can identify a pattern. Now, how do you identify this pattern? Now, small pinpoint pupils usually means that your brain stem is affected. So when you say unilaterally dilated pupil, in neurology, we try to identify the site of the lesion and the nature of the lesion. So unilateral pupil means The localizing sign, something happening on the ipsilateral side of the brain. Bilaterally dilated pupil means something happening globally. So any condition that affects globally or the whole brain, you get bilateral dilatation of pupils. Now, I don't know whether we have time, but what I will try to do is I put the condition, you just tell me what the one, two, three, just type in what it is. Third nerve lesion. Just to me, I don't know whether you are listening. I'm talking to myself. I don't know. So I just want some interaction. I want you guys to type in what you think would be the eyesight. If you have a third nerve lesion, somebody says 3, somebody says 2. Third nerve is not bilateral, it's unilateral. Good. So most of you are saying 3, no? So it's unilateral dilated pupil. So third nerve lesions, you get a unilateral dilated pupil. It's good. So let's go to the next one. Organophosphate injection. Yeah, so good. Most of you are saying it's small pinpoint pupils. Next one is hypothermia. If you followed what I said, you will probably even if you don't know what it is, what the eye sign is, you can guess. Hypothermia. Yes, so hypothermia affects the whole brain. So there is no reason why you should get a unilateral pupil. You should. There is no way you would need to get a small pinpoint pupil because it does not affect the brain stem only. So it affects the whole brain. So it is going to give you a bilaterally fixed dilated pupil. Anticholinergic drugs. Let's say you ingest the anticholinergic drugs. So if you ingest or if you take the anticholinergic drugs, you will get one thing. If you put to the eye, you will get another thing. Yeah. So I mean, we use anticholinergic drugs topically to dilate the eye and examine the eye, like atropine. But if you ingest, of course, you will get bilateral dilatation. Barbiturates. Barbiturates. What is the eyesight? Only 2 have answered. Okay, so let's see what barbiturates do. It dilates the eyes. So like anticholinergic drugs, remember barbiturates will also dilate the eyes. Tentorial herniation. What will tentorial herniation do? So 1 and 3. 1 is small pinpoint. Tentorial herniation. 3. Okay, so let's see what happens. Okay, so why does it have both colors? Now, when you have, say, a ipsilateral lesion that is expanding, like extradural hematoma, what happens first is that there is a part in the brain called the uncus in the temporal lobe, which herniates down through the tentorium. This compresses on the ipsilateral third nerve and causes a unilateral dilated pupil. But as you know, as the EDH builds up, the intracranial pressure rises and rises and rises, and then the whole brain starts to go down through the tentorium, and then the brain simply herniates down the foramen magnum, which is a very, very small, tight ring. And the brain stem is, the whole brain becomes hypoxic. And then you get a bilaterally fixed dilated pupil. So from the time you have a unilaterally dilated pupil up to the time you have a fixed dilated pupil, you have a very short window to save this child's life. To save this child's life, you have a very, 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 very short period. Why are most people leaving? And you need to get the neurosurgical opinion as quickly as possible. So that's why you have both colors there. Right, during and post seizure, during and after a seizure. Anybody? Yes. So during and after a seizure, you get a dilatation of the. I'm going fast because I don't have much time. Hypoxia will cause bilateral dilated pupil. A medullary lesion we talked about gives you a unilateral dilated pupil, and rapidly expanding ipsilateral lesion again gives you a unilateral dilated pupil. Focal seizure is likely to give you a seizures give you dilated pupils. If it's a focal seizure, you get a unilateral dilated pupil. All right. You saw how all these conditions are grouped together into these three patterns. So all you need to remember is the three patterns. So if you get a case and then if you get a child, you look at the pupils, you see pinpoint pupils, then there's an infarct or hemorrhage in the brainstem, or child has taken some poisoning, organ phosphate poisoning. If there's a unilateral dilated pupil, you need to think about, do I need to act quickly? Is this surgical? Do I need to get the neurosurgeon down? Something unilateral is happening on that side of the brain. It might be even something like a seizure, or a focal seizure. But if it's bilateral, then the whole brain is affected. Again, it's a very serious condition. You need to think about the raised ICPs. Is the child coning? Do I need ICU care? All those things. Right. What is that? Okay, so I just so here you have a 2-year-old child who had gone to sleep normally, and then next morning was found to have shallow breathing and is having reduced conscious level. But one important thing that they have noted was the pinpoint pupils. So here in your differential diagnosis, two things that you need to identify. That is, has the child ingested something? 2-year-olds are notorious to be very, very curious about the environment. They will, put anything into their mouth, or has something like a stroke or hemorrhage had happened in his brainstem. So investigation CT at the initial state would be very important in differentiating these two conditions. If the CT comes as normal, you might need to do a toxicology screen. Right. So I'm going to just quickly tell you a few other things. One is unconscious child. One of the most important things to remember is this child having raised intracranial pressure? This is something that will get totally neglected. You think about what the etiology is, what's happening, and this and that. You do not think about pressure building up inside the brain. So you need to know how to identify raised intracranial pressure, all of you will have heard about the Cushing's triad, which is hypertension, bradycardia, an abnormal breathing pattern, and abnormal posturing. But don't this, you can see that the papilledema is crossed out. Now that is crossed out because in acute cases, you do not get papilledema. Only when there is chronic raised intracranial pressure, you will get papilledema. So think about that. You don't need to go probing into the child's eyes, thinking about papilledema and trying to identify papilledema. But any child who has reduced conscious level, think about the raised ICP and think about how to manage that. So the management of raised ICP is twofold. One is the general management. General management is trying to elevate the head and keeping the child as quiet as possible in a very dark environment and trying to reduce his metabolic rate. So you control the fever, control the seizures, control hypoglycemia, control agitation by giving sedating drugs, free noises, and so no noises, all that to the control the environment. Specific treatment is intubation, maintaining the arterial pressure, and giving specific drugs such as mannitol or 3% sodium chloride. And medical management in these cases are sometimes very, very fickle, does not do much. So you need to get the neurosurgeon down very quickly, because that will be the only way you can save this child's life by what is called a neurosurgical procedure called flap removal. Okay, so I'm going to the next part just quickly to tell you a bit about prolonged convulsion of status epilepticus. I'm sure what the definition most people know is that of a seizure that is going on for more than 30 minutes, or you are getting a short lasting seizures without regaining consciousness for 30 minutes. Now this is the most widely used definition for status, but this definition is very about 30 to 35 years old, ILA definition, but they have changed that definition to this. So they have changed is they have put time points. So to say early or impending status epilepticus, that is T1, and then established status epilepticus, what is called T2. So T1 for a convulsive status is 5 minutes. T2 for a convulsive status is 30 minutes. Now doing that, what they want the clinicians to do is, by 5 minutes, they want us to act by giving the first anti-epileptic drug. And by 30 minutes, they want us to be prepared to intubate this child and start the anticonvulsant infusions. So that is the important things in the definition. Now, a few things to remember when it comes to managing prolonged convulsion. One thing is that IV drugs, IV anti-seizure medication, midazolam, diazepam, lorazepam are always superior to giving it buccal or PR. So during that first 5 minutes, the two important things need to be considered. One is getting IV access. So ABC, C is very important. And second thing is thinking about reversible causes. So they always say never, ever, ever forget glucose. So you need to do a CBS at the onset if you are suspecting a prolonged seizure. At the same time, think about the other reversible causes: electrolyte abnormalities, blood pressure, hypertensive encephalopathy, infections, give antibiotics. There are a few causes here: intracranial pressure, bleed inside. So those things are also important. But a few things that we can quickly do would be antibiotics, checking the blood pressure, checking glucose, and sending blood for electrolytes. And then getting IV access. So we have midazolam and diazepam. There's this eternal debate what to give because those are the only two drugs that we have. What they have shown is midazolam is slightly better because midazolam has a higher affinity and a longer half-life than diazepam. So it attaches quickly and the bond to the receptors lasts a little longer. And the implication is that when you give midazolam, you are likely to get less recurrences and you are likely to get a better seizure response than diazepam. And on the other hand, diazepam is not has a little more of a respiratory depressive effect than midazolam. So you are likely to encounter child having shallow breathing and respiratory arrest than when giving midazolam. But midazolam also has potential risk of respiratory suppression. So your first dose would be a benzodiazepine, midazolam, and diazepam. And after you give that, you wait for 5 minutes. And your second dose would be again giving a midazolam and a diazepam or a diazepam, IV or PR. Then your third step. Now the third step, people are slightly now coming out of not giving phenobarbital. Phenobarbital has its own problems. On the other hand, phenobarbital might be more available than other drugs. So the three drugs in contention for the third step are phenytoin, levetiracetam, and phenobarbital. In the APLS protocol, we suggest giving phenytoin or levetiracetam. Phenobarbital, we don't advise for the third step. So when it comes to the fourth step, we interchange. That is, if you have been given phenytoin, you can give levetiracetam. If you have given levetiracetam IV, you can, now for the fourth step, you can give phenytoin. But if both drugs are not available, or if you prefer, you can give phenobarbital at this stage. Few things to remember about the drugs. Phenytoin, of course, has to be given in a very sort of a controlled, assessed environment because it can cause ventricular tachycardia and arrhythmias. You have to have cardiac monitoring, but it is a very good drug to control seizures. You give it over 20 minutes. You need to calculate the dose and make sure that you are not giving a toxic dose. Levetiracetam you give over 5 minutes. Dose is about 40 to 60 milligrams per kg. Phenytoin, phenobarbital, you give 20 milligrams per kg. Again, you give it over 20 minutes. Now, the final step after the fourth step, if the child is still convulsing, you need to do what is called a rapid sequence intubation and start the child on an infusion of midazolam or propofol or thiopentone, either of the three drugs. The purpose of this is once you intubate and give those paralytic agents, that you will not see any electrical seizures. So child might be seizing away inside the brain, but you are not seeing that, but the activity is still present inside the brain. So you need to start an anti-seizure medication infusion, and you need to know how that the seizures are settled. Either you have to have continuous EEG monitoring or you have to have intermittent EEG monitoring. That is how you manage a prolonged convulsion. Of course, it's also important that once you manage the prolonged convulsion, you identify what has caused the convulsion. So, reversible causes we talked about, infections. So you might, at this point, you have to maybe image the child to identify infarction, bleeding, etc. Right. So that concludes my two main lectures, unconscious child and prolonged seizures. Are there any questions? I can take questions. You can either speak out or you can type in. Maybe I can take a few 5 minutes for questions. Seems a lot of people have left. Anything that you need to clarify or not clear? Okay, so if teenager with alcohol abuse comes with a history of fall and head injury, do we need to do the CT? Definitely. Okay, interesting question. Teenager with alcohol abuse. Yes, you can get teenagers now with alcohol abuse. So how would I approach this? What you need to do is, of course, if you followed the lecture, airway and breathing, then look at the circulation, look at the decrease, manage the decreased level of consciousness, assess GCS and all that. Looking at the pupils will tell you whether there is a significant pathology inside the brain, such as bleeding. So if you have a unilateral dilated pupil, answering your question would be very easy. So I would say you have to definitely, do the CT immediately. If you have a bilateral dilated pupil, again, I would say you have to do the CT urgently and maybe manage raised ICP as well. But if the pupils are equal and reacting normally, there's no posturing, just the reduced conscious level, then I think you can probably wait. So unless you have a big skull depression or a skull, a skull fracture that is visible or palpable. Any other questions? One new message. Any more questions? Right. So in the absence of questions, shall we wind up this part of the lecture? Just to remind you what I did, we talked about unconscious child and a child with prolonged consciousness. Both are very, very common clinical scenarios you will encounter during your clinical life. We are very likely to come across either of these two conditions during the first few years of your life, or if you do pediatrics. What the competencies that you need to identify and required gain would be how to assess a child with a neurological deficit. That is quickly 3 things: conscious level, looking at the pupils and posturing, and identify raised intracranial pressure. And then we talked about managing status epilepticus when you manage status epilepticus, you do that according to guidelines. So what we discussed was the APLS guideline. So thank you very much. Wish you all the best for your next step in your journey as a doctor. So thank you. I'll be signing off.
Here we are going to demonstrate how to do basic life support on an unresponsive child. I am Dr. Shamila Tisera, and with me is Dr. Srilal De Silva and Dr. Dhananjay Gunatilaka. So, Srilal, there is this 8-year-old boy who has been found unresponsive in the A&E department of a divisional small hospital in Sri Lanka. Show us how you are going to resuscitate this child on a DRS ABC approach.
Okay, the child, I'm going to check the dangers.
There's no evidence of danger.
Okay. I'm going to check the responsiveness. Baba, Baba.
No, child is not responding to voice or touch.
Can you bring a AED and a bag and mask ventilation and also oral airways? And I'm going to open the airway, head tilt and chin lift.
To a sniffing position,
Yes,
since the child is 8 years, and you can see that the child has no chest movements, no abdominal movements to suggest spontaneous breathing, and you can't feel any breath on your cheek. So child does not have any evidence of breathing.
Okay. So I'm going to do jaw thrust now while maintaining the sniffing position, and again do the look, listen and feel.
Still there is no spontaneous breathing at all.
Okay, no spontaneous. I'm going to give 2 rescue breaths now in the bag and the self-inflating bag. C and E. 1, 2.
Yeah, there's good chest expansion.
Okay. I'm going to check the carotid pulse for 10 seconds now.
Okay, so you can't feel any pulse.
Okay, no pulse.
And when you are bagging, the child did not cough, and child does not have any movements to suggest signs of life. So
okay, I think I need to start on chest compressions.
yeah, he's in cardiac
So,
arrest, so you need to
1
start
and 2 and 3
compressions.
and 4 and 5 and 6 and 7 and 8 and 9 and
So
10
Srilal
and
is giving
11
cardiac
and 12 and
compressions to
13
the
and
lower
14
half of the
and 15
sternum
Then
at a
can you
rate
take
of
over on
100
my
per
count?
minute
Three,
and a
2,
ratio
1.
of 15 compressions to 2 breaths. Make sure the chest is compressed 1/3 the depth of the chest. The child should be in the meantime attached to the
Training
automated
mode.
external
Call for
defibrillator.
help. Analyzing heart rhythm. Do not touch the
Do not
patient.
touch the patient.
Shock advised. Charging. Stand clear.
Charging.
Press flashing shock button.
Start. Stand clear.
Press shock 1 delivered. It is safe to touch the patient. Begin CPR now.
So chest compressions should be given to the lower half of the
Continue.
sternum. The elbow should be straight and the weight should be on the
Continue for
patient.
1.
We can minimize rib fractures. You can see the ventilation
Continue for
is
1
done
minute 30
with
seconds.
the double-handed jaw thrust, maintaining the mask. This is done to minimize
Continue.
aerosol generation, especially with the current COVID situation.
Continue for 1 minute 15 seconds.
11 and 12 and 13 and 14 and 15.
Continue.
1 and 2 and 3 and 4 and 5 and 6 and 7 and 8
Continue
and
for
9,
1 minute.
11 and 12 and 13 and 14 and 15.
15 chest compressions to 2 breaths
Continue.
should be continued.
4 and 5 and 6 and 7, 9 and 10 and 11.
Continue for 45 seconds.
1 and 2 and 3 and 4 and 5.
Continue.
7 and 8 and 9 and 10 and 11 and 12 and 13, 14 and 15.
Continue for 30 seconds.
2, 4, 5 and 6, 7 and 8 and 9 and 11 and
Continue.
13 and 14 and 15.
Continue for 15 seconds.
11, 6 and 7. 11 and 12 and 13 and 14 and 15.
Continue for 5, 4, 3, 2, 1. Stop CPR. Stop now. Do not touch the patient. Analyzing heart rhythm. Do not touch the patient. Analyzing. No shock advised. It is safe to touch the patient. If needed, begin CPR.
So there is spontaneous breathing now. You can feel the breath on your cheek and you can see the chest movements.
Okay.
And
Continue.
there is spontaneous pulse. Regular pulse rhythm is felt.
Continue for 1 minute 45.
So we have put the child in a recovery position and we need to continuously monitor the child while further help arrives. Now, we have demonstrated how to resuscitate a child on basic life support, and we approach the child with care and we check for responsiveness, and then we got help from Dhananjaya.
Good afternoon, everyone. Can you hear me? Can someone say yes? Can you hear me? Yes. Okay, right. Fine. Thank you. So hope you can see the slides also. So welcome to your interactive session on circulatory issues. So I'm Dr. Krishna Pradeep. I'm a pediatrician and a senior lecturer at University of Peradeniya and Teaching Hospital Peradeniya. And I'll be speaking to you on circulatory issues. It's a part of assessing and managing a seriously ill child. So you are familiar with this pediatric assessment triangle where we use a ABCD approach. And I'm sure we are all familiar why we use this ABCD. Why not BCD or why not DABC, right? So the factor which is deciding that is what can kill a child quickly. What is the most important or more prominent thing which can kill a child quickly? So it's airway first, followed by breathing, then circulation. That's why we go in an ABC approach, right? So these are the components which you would have learned earlier in this session. So you would have learned about airway and breathing. Now I'm going to focus on the circulation, right? So when it comes to assessment of circulation, or when you are assessing the circulation of a critically unwell child, there are few bedside parameters we all will be using, right? So when it comes to circulation, we would be checking the pulse rate, pulse volume, capillary refilling time, line of coldness, the skin color, and the blood pressure, right? So depending on the age of the child, you might check the pulse either in femoral, radial, brachial, or carotid, depending on the age. And you can check the pulse volume. And capillary refilling time again can be checked in the sternum or in the fingers or in the nail beds. So likewise, depending on the age and depending on the baby's size, you would decide these things. The important question here is, why are we checking these parameters to assess the circulation? In other words, how will these parameters will tell you about the circulatory problem? Okay. So for that, you need to understand this table. So this is called as global hemodynamic relationship. The global hemodynamic relationship means it is telling about oxygen supply to the tissue. So this DO2 is the oxygen supply or oxygen delivery to the tissue, which is equivalent to cardiac output, that is CO, cardiac output into hemoglobin into saturation. So when your oxygen supply to the tissue, oxygen delivery to the tissue is insufficient, you say child is having a circulatory problem, or you would say child is in shock. So if your child is in shock, you will have abnormalities to the oxygen supply to the tissue. So that will be reflected on cardiac output, hemoglobin, and saturation. So how will you know whether the oxygen supply to the tissue is normal or abnormal? So cardiac output is directly proportional to the mean arterial pressure. That means the cardiac output into total peripheral resistance is your mean arterial pressure. So if your cardiac output goes up, your mean arterial pressure will go up. The cardiac output goes down, the mean arterial pressure will go down. Now your hemoglobin and saturation, of course, you will be able to calculate hemoglobin by checking the full blood count, oxygen saturation with the pulse oximeter, right? Your cardiac output is derived from heart rate into stroke volume. So if you know the heart rate and if you know the stroke volume, that will give an idea about the cardiac output. That will give an idea about the oxygen supply to the tissue. Now, heart rate, of course, clinically examination, you will be able to check. Stroke volume, how are you going to check? The stroke volume would be reflected by preload, afterload, and cardiac contractility. So basically, these parameters ultimately is going to give rise to cardiac output, and by that you will be able to know the oxygen supply to the tissue. So by checking the blood pressure, both supine and seated, you will know the mean arterial pressure. As a result, you will know the cardiac output. As a result, you will know the oxygen supply to the tissue. So by knowing whether your blood pressures are normal, you know the oxygen supply to the tissue is normal. Now, the total peripheral resistance, by checking the peripheral perfusion, if your peripheral perfusion is good, total peripheral resistance is low. If your peripheral perfusion is very poor, that means the total peripheral resistance is high. So by checking the peripheral perfusion using the capillary filling time, or whether the peripheries are warm or cold, you are going to get an idea about the total peripheral resistance. As a result, you are going to get the idea about the cardiac output. So yeah, this is what cold peripheries and the capillary fill time. Then the heart rate. Heart rate can be examined by auscultation of the heart or by checking the pulse. You can check the pulse rate and pulse volume. So if you know the pulse rate and pulse volume, you will have an idea about the cardiac output and indirectly our idea about the oxygen supply to the tissue. Then what about the preload? Preload can be calculated using JVP, CVP, PAOP, and size of the liver. These parameters will give you an idea about the preload of the heart. Then what about the contractility? If your gallop rhythm, the presence of gallop rhythm will say there is heart failure. As a result, your contractility is poor. And similarly, preload features also will give an idea about the contractility. So if you know the preload, if you know the contractility, that is going to give an idea about the stroke volume, and as a result, you will know about the cardiac output, and as a result, you will know the oxygen supply to the tissue. Afterload, of course, by doing an echocardiogram only, you will be knowing the afterload. Therefore, afterload cannot be calculated with any of these clinical parameters. So what I am trying to say is, your oxygen supply to the tissue can be checked. Now, it's something happening in the tissue level. It's happening in the cellular level. But that can be clinically assessed in the bedside by just checking the pulse rate, pulse volume, capillary fill time, peripheries warm or cold, blood pressure, and the JVP size. These simple clinical parameters are going to give an important information about your tissue level process. What is happening at the tissue level? What is happening at the cellular level? So what I am trying to emphasize is your checking of pulse rate, pulse volume, capillary fill time, and all the other parameters is going to give you the information which is very, very vital, that is oxygen supply to the tissue. So as a result, if the oxygen supply to the tissue is insufficient, you know child is in shock. Hope this is clear. So again, take this formula into your mind and again emphasize the importance of clinical bedside parameters assessment in a child who is having a circulatory failure or in a child who is critically unwell. So the same parameters I have put in this table. So whether the extremities are warm, skin color, pulse rate, capillary fill time, your central pulse, blood pressure, and all. Now these parameters are going to give you an idea about whether the child is in shock or not. So again, shock can be classified into two groups, compensated or decompensated. So there are certain parameters which are going to be same in compensated and decompensated. For example, extremities temperature. So extremities are going to be cold in both the conditions. But tachycardia, in compensated, you will just get a marginal tachycardia, whereas decompensated, you will have severe tachycardia. And your blood pressures are normal in compensated shock. So understand the fact that blood pressures can be normal in children despite the having shock. So in compensated shock, the blood pressures can be normal. Whereas when it goes to a decompensated level only, the blood pressures will start falling. So you need to take that into your mind. Normal blood pressure does not exclude shock in children. And sensorium, they can have mild agitation in compensated shock, whereas they can have a depressed cerebral state in decompensated shock. So again, now checking these bedside parameters will not only give you an idea about shock or the oxygen supply to the tissues, but also it will be helpful for you to differentiate compensated shock from uncompensated or decompensated shock. Now, a child comes with shock. We'll say it's compensated or decompensated, whatever. What are you going to do? You are going to get an IV access. If you are unable to get an IV access, you need to get an IO access. When you are getting IO access or IV access, you need to take blood samples. In IO access, you cannot take a lot of samples, but if it is IV, you can take blood sugars, full blood count, blood culture, electrolytes, blood gas, grouping, and RH. And you will have to start on fluids. So if a child is in shock, generally what we will do is we will use 0.9 saline, 20 ml per kg rapid bolus. When a child gets admitted with shock but hypovolemic or hemorrhagic, the basic principles are going to be the same. But if there is hemorrhage, you will go for blood transfusion. So, what is the pathophysiological mechanism behind hypovolemic shock? What exactly happens? So, when there is bleeding or when there is hypovolemia, your cardiovascular system is empty in fluids. Because there's less fluid, your heart will not have enough fluid, your circulatory system will not have enough fluid, therefore your system is empty. When the heart does not have enough fluid, there is inadequate myocardial contractility. Therefore, the body will sense it and it will know that blood pressures are low. There will be sympathetic overactivity, which will lead to vasoconstriction in order to maintain the blood pressure. Now, your blood pressure might go up a little bit, but despite normal blood pressure, organs are poorly perfused due to reduction in the blood flow. So, what happens? Your organs are going to suffer hypovolemia and hypoxia. So, this is what happens in hypovolemic shock. Now, hypovolemic shock can be due to two causes: non-hemorrhagic causes and hemorrhagic causes. Non-hemorrhagic causes are like vomiting, diarrhea, intestinal obstruction, burns, diabetic ketoacidosis, etc. Hemorrhagic shock is due to trauma, GI bleed, post-operative blood loss, and in adults and in females, it's ectopic pregnancy. So that is the pathophysiological mechanism behind hypovolemic shock. So we are going to discuss about few cases. I would like the participants also to actively get involved in the discussion. So can I have one of the participants to read this? Anyone volunteer? So Buddhini Dolapihilla. Buddhini, are you around? Buddhini, can you unmute yourself and read this? Buddhini, you're not there. Harshana, AD Harshana, are you around? Harshana? So we have to assume that you are not in the session, huh? You are not reading. Chamat Nirmal, are you around? Chamat? Anyone? Any volunteers? Damitu Pereira, can you read this, Damitu? Can someone read this? No, whoever the names we call, if you don't respond, that means you are not in the class, huh? So you are unable to unmute. Okay, then fine. Okay. So I have got messages saying that unable to unmute. Okay, I will read then. A previously well 10-year-old girl admitted with high fever with chills and rigors for 3 days duration. She was progressively drowsy and was warm to touch on admission. On examination, she had a respiratory rate of 35 with no recessions, a pulse of 148 low volume with capillary fill 5 seconds. Blood pressure was 70 by 30. She responded to voice. Her temperature was 39.5. So what are the salient points in this history? High fever with chills and rigors, drowsy, tachypnic, pulse rate is 148, low volume with capillary fill 5 seconds, and blood pressure is also low. So this the child is in hypovolemic shock. Then we'll have to look into why this child is in hypovolemic shock. So later, child has watery diarrhea, few petechial patches on her back and front of the chest. Her consciousness deteriorated and responding only to deep pain. One of her schoolmates were treated for brain fever in the hospital. In the images, you see some petechial and ecchymotic patches, and they are doing the glass test. It will show it's a non-blanching rash. So what are you going to do? So it's a septic shock. So when it comes to airway, you will have to call for help, open the airway, put oral airway, and if needed, if the child is drowsy or child is not responding, you will have to intubate. So you have to support the airway basically. When it comes to B, child is grunting, having a respiratory rate of 35. So always put on high flow oxygen and monitor saturation with the help of pulse oximeter. And the main problem is child is in shock. So there's circulatory problem. We'll have to put IV cannula, take important bloods. You have to start on fluids 20 ml per kg, and if needed, you can repeat. And sometimes if the blood pressures are not improving, you will have to start on inotropes. And when it comes to disability, child is responding only to verbal only the verbal response is there, and later it has turned out to be responding to pain only. So GCS is dropping, therefore you'll have to do airway protection. Then when it comes to exposure, definitely remember about IV antibiotics because it's a septic shock. Maybe you can give the antibiotics even very early in the circulation and continue to reassess. This is a case of septic shock due to meningococcal sepsis. That is case 1. Case 2, this is a 10-year-old child was immediately brought to LRH for children as she apparently developed reaction following a vaccination. Weight is 30 kilos. She has swollen eyes and lips and widespread urticarial rash. Respiratory rate is 28 per minute and pale and sweaty. Saturation 94, pulse rate 140, moderate volume, blood pressure 75/40. So if you look at these images, you have swollen lips, urticarial rash, abdominal pain, all these parameters, right? So invariably it's an anaphylactic shock you are dealing with. After a few minutes, her shock got worse. Pulse rate goes to 190. She looks pale. Systolic blood pressure falls to 70/30. So there is hypotension and child is in shock. So what is the management strategy? So in the airway, look for stridor, call for help. Because child is in shock, raise the foot end of the bed. In the breathing, so check for respiratory parameters, recession, rate 50, saturation 88. So remember to put on high flow oxygen. Then in circulation, pulse rate is 190, blood pressure 80/40, capillary fill time 4 seconds. So circulation is a problem here. So what are you going to do? Are you going to start with fluid bolus here? No, this is an anaphylactic shock. The first treatment choice should be IM adrenaline. Fluids you might have to give, but later, because for fluids you will have to put IV cannula, then start. It takes time. Treatment of choice in anaphylactic shock is IM adrenaline. So the dose is 0.01 mils per kg, 1 in 1000. So undiluted adrenaline, so whatever adrenaline you have in the hospital, which comes in ampoules, the same adrenaline without diluting, you will have to start. So this is given as IM. into the lateral aspect of the thigh. Now, for you to easily remember the dose, rather than remembering this 0.01 mils per kg, and especially when you don't know the weight in an emergency situation, if the child's age is 1 year, you can give 0.05 mils. Child is around 10 years, 0.5 mils. Child is an adult, you can go up to 1 mils. In between, you can take a middle number and manage. Hope that is helpful. Right? Then after giving IM adrenaline, then you have time to insert a IV cannula, take bloods if needed, start on normal saline fluids 20 mils per kg and repeat as needed. And repeat IM adrenaline every 5 minutes. But the current the new guideline says after first 2 IM adrenaline, if the child's condition is not improving, go for IV adrenaline. Okay, so we are not going to speak about that here, but remember IM adrenaline twice, if not improving, to go for IV adrenaline because it's a refractory anaphylactic shock. Then when it comes to disability, you have to assess the GCS and remember to remove the allergen. If the child has come with anaphylaxis due to skin contact or something, try to remove the allergen. You can wash the child, you can remove the clothes, whatever possible, right? And reassess the child whenever needed. That's the case number 2. It's anaphylactic shock following vaccination. Right? So we'll go into the third case. A 4-year-old child with 3 days history of high fever, not responding to ordinary doses of paracetamol, admitted to hospital. Respiratory rate is 20 per minute with no recessions. Pulse rate 100, good volume. Capillary fill time is less than 2 seconds. Blood pressure is 80/45. Liver is 3 centimeter palpable. White cell count 1.8. Neutrophil 27%. Platelet 98,000. PCV 36.3. SGOT-PT high 900 and 700. So basically, when you go through this story in the Sri Lankan context, you know this is a child with dengue fever. Is the child in shock now? No. The pulse rate looks okay, pulse volume is okay, capillary fill time looks fine. Blood pressure, of course, marginally low, but other parameters are not suggestive of a shock. Right? Then what happens? So, yeah, this shows that child is developing a pleural effusion on the right side. That is a decubitus push chest X-ray. The PCV is rising. 12 hours after admission, he was pretty cold. With respiratory rate is 22, pulse not palpable, capillary fill time more than 5 seconds, blood pressure 50/25, liver 4 centimeter. Still responding to voice, vomiting, coughing ground stuff. Now the repeat SGOT-PT has gone up to thousands. So here now, initially we told child was not in shock. Now what has happened? Child has gone into a shock. So pulse is not palpable. Blood pressure is 50/20, very low. So it is dengue hemorrhagic fever, compensated shock or uncompensated. It's a uncompensated shock because you are not able to feel the pulse. The blood pressure reading you are getting on the machine may be a wrong one because when you can't read the blood, take the blood pressure, you take it as when you can't feel the pulse, you take it as blood pressure also unrecordable. So here what you do, child is drowsy, so call for help and high flow oxygen. As the child is having some recessions, put on oxygen if needed, or monitor the saturation. Try to get IV access and to take inward PCV, do inward PCV, send basic bloods. Important ones here are whooping and RH and to do a SGOT-PT and clotting. Now, in a dengue child, if you had to give dextran, after that, if you do whooping and DT, there can be incompatibilities. Therefore, before dextran, you will have to take blood. So that's why when you put an IV cannula compared to other scenarios here, you will have to take blood for whooping and DT. Now, if it's a compensated shock, you will have to start on normal saline fluids 10 ml per kg over 1 hour. If it's uncompensated shock, you will have to start on 20 ml per kg rapid bolt. So depending on the case, you will have to start whatever needed. And sometimes you will have to go for dextran as well or blood transfusion depending on. So these are general principle for any dengue shock, but depending on the case, depending on the parameters, you will have to change your management strategy. That is a case of dengue shock. Now, dengue shock is a distributive shock. So not only dengue shock, anaphylaxis and septic shock also partially it's a distributive shock, and sometimes neurogenic shock is also there. Now, what happens in a distributive shock? Now, in distributive shock, now for example, in dengue, you'll see what happens is basically your pipes are leaking. That means your vessels are leaking fluid. So pipes are too leaky. So you give fluids, it leaks. So because of leaking fluids, blood vessels do not have enough fluids. Therefore, your sympathetic system will detect it. In order to maintain the blood pressure, the blood pressures would go down because of the leaking, and vessels are also dilate. In a distributed shock, vessels also will dilate. Therefore, you will have hypovolemia. So basically, it's a leaky pipe or a leaky tubes and empty system. So you have to give adequate fluid therapy for the heart to compensate, but then heart will try to compensate by increasing the heart rate and the contractility of the heart. So this is what happens in the distributed shock. So another case, previously well 12-year-old child admitted with high grade fever for 5 days, recurrent vomiting since day 4 of the illness, abdominal pain, headache, neck pain. Child is febrile, very ill looking, dehydrated, bilateral conjunctival redness with generalized rash, heart rate 140, good volume, capillary fill 3 seconds, blood pressure 90/50, peripheries warm, no murmurs, GCS 15/15, signs of meningism. What do you think? What is the diagnosis of the child? So can this be a dengue? Can this be a viral fever? Whether the child is having some CNS involvement? So initial investigations, white cell count was 11,000, neutrophil 85%, platelet 88,000, ESR 103 and CRP 228. So very high ESR, very high CRP, but there is lymphopenia and neutrophilia. What is it? 2 months back, paternal grandparents were positive for COVID-19, denied by mother initially. Now, if you go back to the case again, you see a child with high fever, recurrent vomiting, abdominal pain, headache, neck pain, also has bilateral conjunctival redness with generalized rash. So what is this? If you look at the clinical history thoroughly and examination and investigation, you will get a clue, and especially with this bilateral conjunctival redness, this is a child, a case of MIS-C, right? So MIS-C children, so after COVID infection, children can come with MIS-C, and MIS-C children can present in a shock state. That you need to remember. Nowadays, the cases have gone down there. You don't see MIS-Cs, but during now this presentation was done maybe a year or two ago. So that time there were a lot of MIS-C cases. That's why this case was included for the house officers for them to learn. Next case, a 4-year-old child admitted with 3 days history of low-grade fever, coryza, nasal stuffiness, mild cough. On admission to the hospital, she was sweating off feeds. Her respiratory rate was 28, no recessions. Pulse rate was 180, low volume, whole peripheries, with blood pressure 60/35, fever 5 centimeters, responding to voice, actual temperature 38. Now, if you look at the story, first row, it looks like upper respiratory tract infection or a viral fever. But then child is sweating a lot, respiratory rate is marginally high, pulse rate is high, low volume, The child is in a shock. In addition to that, liver 5 centimeters. Now, when do you get this sort of picture? This can be a sepsis, or this can be dengue sometimes. Dengue also can have all features of viral with a liver 5 centimeter. So this can be something else. So it's sort of a very confusing case. So, but child is already in impending shock because pulse rate is 180, low volume, cold peripheries, blood pressure is low. So what will we do generally when a child is having these symptoms and has shock? What are we going to do first? We would go for a fluid bolus, isn't it? That is what usually we'll do. So further information, a diagnosis of dengue shock was made. 2 boluses of normal saline was given over 40 minutes. So rapid boluses have been given. Child seems to develop more distress now. So earlier child had some mild distress. Now of course more distress. Respiratory rate of 30 has gone up a bit. Pulse rate 200 has gone up very much. 3D, peripherals remain cold. Blood pressure was 70 by 40. A child is responding to voice with difficulty as she is breathless. So what has happened? After your 2 fluid boluses, child's parameters has got worsened. So heart rate has gone up and difficulty in breathing has gone up. So why? What has happened? So if it is dengue shock, then after giving 2 fluid boluses for this to happen, either it has to be a fluid overload or it has to be a effusion getting worsened. So those are possibilities. Are there anything else other than this? Right. Further information, a gallop rhythm is heard on auscultation and levi is for enlarged still 5 centimeters. Right. So after your fluid bolus, the child became more distressed and a gallop rhythm is heard now. So what does it mean? It has to be either fluid overload, heart failure, or what is the other possibility here? Because on arrival itself, child had a liver for 5 centimeters. So this can be a different diagnosis. What do you think? Anyone? You can type it on the chat. What is the diagnosis you think here? You can type it. Whether this is dengue shock fluid overload or whether this is something else. Acute liver failure, okay. Any other? Viral myocarditis, okay. Any other? Or whether it's fluid overload. Okay, this is in fact a case of viral myocarditis because this is a child who had come with symptoms suggestive of a viral infection. On arrival itself, child's liver was big, hepatomegaly. Now after the fluid boluses, it has got worsened. So it's a viral myocarditis. So it's common for you to come across similar cases in your practice. You might think of dengue in a child, you might give fluid, but the child's condition gets worsened. You will have to suspect viral myocarditis. Right? So it's a case of viral myocarditis. Good. So in the pathophysiological classification, viral myocarditis belongs to cardiogenic shock group. Right? So when the child comes with cardiogenic shock. So your child is in shock, but the problem is in the heart. Right? The reason is there's a cardiac cause. So viral myocarditis is an example. There are some other examples also. So in the airway, always remember to open the airway, look for recessions, rate, saturation. If needed, you will have to go for high flow oxygen. When it comes to circulation, try to get IV cannula or also try to assess the intravascular volume status with a scan. Because if the intravascular volume status is good, here there's no problem with the intravascular volume status. It is in fact the myocardial contractility is a problem. You should not push too much fluids, that can make the condition worse. Then here you are trying to not to give too much fluid. Therefore, always remember use normal saline 10 ml per kg fluid boluses. and check on the hepatojugular reflex while giving fluid. If your hepatojugular reflex is positive, then you will have to think, right? And sometimes you will have to go for inotrop rather than fluid overload. Might have to go for inotrop, especially milrinol. And you will have to see the disability and decide what to do. So cardiogenic shock, the main problem is poor myocardial contractility. When there is poor myocardial contractility, that means your pump is failing. Therefore, there's little blood coming out of the heart. So sympathetic overactivity leads to vasoconstriction in order to maintain blood. So again, there will be vasoconstriction to maintain the blood pressure. But despite normal blood pressure, organs are poorly perfused due to reduction in the blood flow. And because your cardiac contractility is poor, your heart is failing, there will be high venous pressure, which will lead to fluid extravasation and edema. So that also you will see in children with cardiogenic shock. So whenever a child comes to your unit with shock, see these parameters which will help you differentiate what shock. So children can come with septic shock, dengue shock, anaphylactic shock, cardiac failure. Now, the important parameters are your liver is generally not palpable or normal in size in most of the shocks. Septic shocks, sometimes it might go up a little bit, but you don't see a significant liver enlargement in these conditions. So significant liver enlargement suggests of a cardiac failure. And gallop rhythm is generally not seen in any of the shock, but it will be seen in heart failure or the cardiac failure. Femoral pulses can be absent in a newborn who presents with cardiac failure, right? So that is the other thing you will have to remember. Murmurs are present when there is a cardiac failure, and hepatojugular response is present in cardiac failure. So when a child comes with units out of shock, it's important for you to differentiate whether this is cardiac shock or any other shocks, because if it is other shocks, you can freely give fluids, but if it is cardiogenic shock, you will have to limit your fluids. So that is a key learning point you need to keep remember. Directed case 6, the next case. 8-year-old boy attempted to ride a push bike at speed down his sloping front yard and out through his front gate. He miscalculated his pathway and slammed into gate post, and he bounced back onto the footpath. The gate latch has torn a large and ragged wound in his thigh. So there is a wound in the thigh. So basically, a child is riding the cycle, has gone and hit the gate post. There's a trauma to the thigh. The estimated weight is 25 kilos. Pulse 125, blood pressure 110, saturation 95, respiratory rate 25. He is groaning and complaining of pain in his left leg and left side of the chest. So he's not only having left leg pain or trauma in the left thigh, but also has a left side of his chest also he is complaining of pain. There is progressive increase in heart rate to 140, but the volume is good. Respiratory rate 35, blood pressure 115/75, saturation 93 in oxygen, and he has tenderness and decreases air entry on left. So what is the cause here? A child who has a trauma to chest. What would be the problem here? Anyone? So think what could be. So there is progressive increase in heart rate, respiratory 35, saturation dropping, and he has tenderness and decreased air entry onto the left. Right? So that is an obstructive shock. It can be a tension pneumothorax, or it can be a cardiac tamponade if the heart sounds are muffled. So you have to think of obstructive shock. When you have obstructive shock, again open the airway, put on high flow oxygen, IV cannula, maintenance fluids, needle thoracentesis. If you have a tension pneumothorax, not the normal pneumothorax, but the tension pneumothorax, you will have to go for needle thoracentesis. Right? So remember to do a needle thoracentesis, and later you can get a IC tube inserted, which is going to be permanent for some time. So that is about obstructive shock. So obstructive shock, myocardium is contracting, but against a high afterload. So there is some obstruction. So therefore, myocardium has to contract again. The pump is obstructed. Therefore, blood pressure is low. So sympathetic overactivity lead to vasoconstriction, trying to maintain the blood pressure. Despite normal blood pressure, organs are poorly perfused. Then back pressure leads to venous congestion. So that is the pathophysiology behind obstructive shock. So basically, to summarize, your management of shock. So there's a question. This boy complains of severe pain. When should we address that? And what is the ideal drug for pain relief? So when you do the primary survey, when you do the quick ABC assessment, you need, because when you give pain relief, sometimes child might become drowsy. So your assessment might be a little bit worrying. So you have to do a quick assessment. After initial ABC assessment, you can give midazolam. Sorry, you can give morphine, right? You can give IM morphine, or you can give intranasal fentanyl. Intranasal fentanyl also can be good. So in our setup, midazolam is excuse me. Morphine is common. We use morphine, or you can use intranasal fentanyl. So that can be used. It's as after the initial primary survey, you can give the pain relief. So management of shock, you can use 20 ml per kg fluid bolus depending on the condition. Most of the condition you can go for 20 ml, but 10 ml per kg fluid bolus only in newborn babies under 1 year sometimes, heart diseases, decay, dengue shock, compensated shock, and trauma patients also, because to preserve the primary clot, we go for 10 ml per kg. So what is the general principles of management in a shock child? So position is important. Keep flat toe, elevate the legs. Try to open the airway. Put on high flow oxygen, IV access or IO access, and take bloods. Fluid bolus. Later you can put on maintenance fluids. Think of inotropes if needed. Adrenaline or adrenaline. Sometimes vasopressin or steroids. And if it is anaphylaxis, always start with IM adrenaline, then fluids. If it's a drug-dependent congenital heart disease, think of prostaglandin, because it is needed to keep the ductus arteriosus patent. And remember to give antibiotics in any septic shock and try to give it early as possible. And what are our targets in a resuscitation? Try to maintain urine output more than 1 ml per kg per hour, normal mental status, normal acid-base balance, normal lactate, and SCPO2 over 70%. So these are few examples of vasoactive agents and what receptors they act on. So dopamine, adrenaline, noradrenaline. So you have to learn, you have to remember is dopamine mainly beta 1, adrenaline can act on alpha or beta any, but their main action is on alpha 1, alpha 2, and beta 1, whereas noradrenaline in both alpha 1 and alpha 2. Right. So that concludes our session. Unfortunately, due to some problem, you are unable to unmute your mics. If you have any questions, you can type it on the chat box. We have a couple of minutes more. Any burning questions? Right. So in the absence of the questions, let us wind up the session. Thank you very much. So you will be informed about your next session from me. Thank you.
Now lunchtime, come to 1:45.
I think yes. I think you can hear me.
Yes, ma'am.
Yeah. So now we'll start the introduction. So this is a lecture you have heard many times, right? But different aspects during your undergraduate career. Since it is very important topic, we also thought that we should do it. Just a moment, please. Sorry. Right. So in this lecture, this half an hour, I'm going to talk about few aspects like how the dengue illness progress, how to diagnose, how are we going to admit, and who are the children need admission, and also a little bit about management of DHF and the recovery. As you all know, there are new guidelines, or the revised guidelines are released. And pediatric or children and adolescent also, we have released recently the new guideline, which is available. So you all can go through that for detailed information about management. So there are 4 serotypes of this virus. Each serotype has a different severity, and each epidemic, when we see these different serotypes, we see. Again, the presentation can be very common to serious, like a lot of us we get, but we are asymptomatic when we get the infection. But some can have a flu-like illness, but some may, or very few may end up with dengue fever or dengue hemorrhagic fever. This is why we don't worry about, even though the second infection can cause serious effects. We don't worry because most of us may have had subclinical infection. There is no exception for age group, starts from neonates until elderly period, they can have dengue infection. But we need to be careful at the beginning. It may be difficult to differentiate from other common childhood infection and febrile illnesses. So because of this, whenever a child presents with 2 days or more history of fever without any other reason, we always consider dengue as a differential diagnosis and try to exclude that. High risk, actually speaking, if we manage well, there is no risk, but we have to manage, especially infants, children with other comorbidities like thalassemia, malignancy, nephrotic syndrome. Obese children have a little bit of a higher risk, and the child who is having any form of bleeding, including even a menstrual bleeding or bleeding tendencies due to ingestion of NSAIDs, we need to be careful because they can have a high risk. Now, why we are talking about DHF, that is the dengue hemorrhagic fever, now we have come to a stage, if they come alive to hospital, it has become a treatable condition. All these days we were talking about preventable, but now we think it is treatable, because when the management improved, the case fatality was also coming down. So every patient who comes or who is diagnosed with dengue hemorrhagic fever should get an optimum care, because the recovery is almost 100%. So what our worries when we manage managing a child with dengue hemorrhagic fever is, first we worry about shock. They can go into circulatory collapse. Sometimes if we treat with wrong fluid management or overhydration, then it can also have serious consequences like fluid overload. Both can lead to multi-organ failure if we don't treat appropriately. But more than everything, we don't want to see death. It may be due to secondary infection or shock or fluid overload or bleeding, any cause which may be related to dengue. So now we will move on to just to brief, what is the natural cause of the dengue illness? Now this diagram shows, or this graph sort of thing shows the x-axis. If you see, different phases have been marked: febrile phase, critical phase, and the recovery phase. So the time period. So at the top we have put the number of days. So then, and also different parameter, how it can change, is written on the y-axis. So between DF and DHF, there's between both of these conditions, both are different conditions as far as the management and outcome is concerned. So DHF will have an additional phase that is called critical phase. You can see in the middle. So after the febrile phase, if a child has dengue fever, once the platelets start dropping, after that they will directly go into recovery phase. So this purple or pink color column will not be there for patients in DF. But DHF patient, once the febrile phase is going to be over, then there is a special phase starts that is called critical phase or leaking phase, which is the more important phase, because during this period, the patient can go into shock. There can be increased tendency to bleed. And if we don't manage appropriately, the patient can go into organ impairment. So this is why all these dengue patients, when their platelets start dropping or fever start coming down, or after day 3 of the illness, we want them to be admitted. If you can see, the febrile phase is the viremic phase. So during that time, if you look at the lower part of the febrile phase, you can see it's a viremic phase. This is the time our specific antigen, we call it NS1 antigen for dengue, will be positive. That is why we tell, if a child has fever, generally NS1 test will be positive during the first few days of illness. So maybe 1, 2, 3 days, that may be the time. After that, that virus amount will come down and the antibodies start rising. So in critical phase, we may not see NS1 antigen as a positive test. If you are doing lately, if any specific investigation, that has to be IgM or IgG. So if you are going to do a NS1, that is helpful for the early diagnosis of dengue, which could be dengue fever or dengue hemorrhagic fever. If you see the second part, how the platelet and hematocrit changes. So the platelets start coming down when the fever also starts settling. So generally we tell the mothers also, when the fever comes down, when they ask when, so we say the platelets start coming down, that's the time fever also going to come down. You can see how the hematocrit can rise if we don't treat during the critical phase because of the plasma leakage. So usually the critical phase starts when the fever comes down. So the fever can go up to 40, 41 degrees centigrade during viremic phase or the febrile phase. So during this period, some of the children who have the tendency to develop febrile convulsion may present with febrile convulsion very early. Or if they don't take adequate fluid, so they can end up with dehydration. This can be common for DF or DHF. Okay, so the DHF means there is some amount of plasma leakage, which can vary from person to person. So now we have got a patient who has DHF, that means there is plasma leakage. There are 2 important pathological changes we notice in critical phase. One is leakage of plasma. Second is there is a high tendency to bleed. So even slightest change, they can bleed. So this plasma leakage generally takes place for about 48 hours. So it gradually starts rising up, then coming down gradually. So this is the way it leads. So it is dynamic. You can see At different time, if you look at within this 48 hours, patient will leak at different levels. So we can't put a same amount of IV fluids or oral intake throughout the critical phase because there is a lot of dynamics takes place. So the leaking phase, generally we say 48 hours. Remember, infant and children can have a shorter duration, maybe 12 to 36 or 12 to 24 hours. So we have to be careful. It can be shorter or rarely it can be longer, but maximum most of the time we expect about 48 hours. So how do we know whether it is shorter or longer? The one way of knowing is the monitoring. This is where the monitoring comes very important. So we will go into this detail about the clinical parameters, vital signs, urine output, PCV. There are so many things we monitor for these patients to identify whether they have gone into critical phase, how to manage their fluid, and whether we can stop our monitoring and the fluid management since they have gone out of critical phase. So how do we diagnose these patients? We know whenever somebody comes with a fever, high fever, 2 to 3 days, nowadays we have a strong suspicion whether this is dengue. So when a patient comes with clinical features suggestive of fever, arthralgia, myalgia, retroorbital pain, mild bleeding manifestations, there may be some respiratory or a GIT symptoms. There may be a family, other members may be affected, or neighborhood, there are cases of dengue. So you have to strongly suspect dengue. It could be dengue fever, it could be dengue hemorrhagic fevers. So then we generally ask for 2 to 3 investigations, full blood count. The WBC count is very important. Most of the time it is less than 5,000. So you start seeing a leukopenia in the full blood count at the beginning of the disease, second, third day. So the platelet count start dropping only after third day, right? Unless we do a serial count, we won't do. That is why if we want to know whether it's dengue infection or not, we can do a NS1 antigen test, which can be done at the very early febrile phase period. But remember, if it is positive, it is highly specific, then you don't have to think about other diseases. But if it is negative, there is a problem that it may be still dengue cannot be excluded. C-reactive protein in a viral disease, it can be normal, but mild to moderate rise is very commonly seen, maybe up to 20, 30, we commonly see, not to think it is a bacterial infection. So laboratory, so whenever we have a patient, we have to don't forget about the clinical features because clinical assessment is the key. So you laboratory reports also be correlate with the clinical assessment. How do we know this is a severe dengue or dengue hemorrhagic fever? So when you look at the patient by third day or fourth day, very lethargic or ill look, if they complain of abdominal pain, bleeding, even if they have a menstruation, I'm not talking about the minor bleeds like, gum bleed or some tender hepatomegaly especially. And if the patient's PCV is gradually rising from the baseline, right? Gradually rising. We don't, at the beginning, we won't expect 20%, but it goes towards 20%. And again, up to 12 years, if anything more than 42%, we consider as there is some amount of rise in PCV. But now we get 12 to 14 years also. So sometimes you might see 42 can be normal for them. Whenever the platelet count is below 100,000, ask a question, am I dealing with a patient DHF or DF? DHF, about almost 100% will have below 100,000 platelet. But DF, still it is possible, but not very low, but maybe 50 to 100,000 in about 30 to 50% of the children. If we have facilities for, at the point of care, if we can do an ultrasound scan, we can look for evidence of leaking. Remember, who does the scan is people like us, not the radiologists. So don't rely too much on the ultrasound scan when the clinical features are suggestive of dengue hemorrhagic fever. So vitals are very, very important in any patient. The important thing is just holding the hand itself, most of the things you can diagnose, whether your patient is in shock or not. That means extreme examine the peripheries, whether when you feel the pulse, you might feel cold or warm peripheries. What about the pulse rate? What about the volume? And also in the peripheries, you can do a capillary refilling time. So if these are suggestive, then you can check the blood pressure. But even if the blood pressure is normal, still you have a patient with shock. So I will go through a little bit about the management of the outpatient or the early febrile phase. Rest, any viral disease will benefit by rest and hydration. Paracetamol, it's only about 15 milligram per kg for about 4 times a day. Remember that paracetamol we are giving to make the child comfortable, not to abolish the fever, right? So there can be fever, but only thing is, it is to make the child comfortable. So it has to be told to mother. Fever will not come down to 37, maybe 38, right? And reassure the mother, this is viral, this is dengue illness, it is like this. Because most of the mothers think when the fever doesn't come down to 37, they go and ask for some stronger medicine, where NSAID, mefenamic acid, steroids, those things are prescribed. So that has to be stopped. Daily review with full blood count and simple advice on warning symptoms. I have told you, persistent vomiting if they can't take orally, right hypochondrial pain, giddiness, dizziness, or low urine output, they need to come to hospital irrespective of their count. Even if they haven't done the count, if they feel or bleeding manifestations, I think they should come to hospital for admission. So now we will talk a little bit about DHF. DHF hallmarks, there are 2 important problems occur. This starts at the end of the febrile phase. So you might see a very high spike, and after entering into critical phase, it will come down to maybe a very low temperature, or maybe low means below 30, 38.5, or no fever. In addition to leaking, if the patient is not improving, try to see whether there is any bleeding happening in your patient, because this phase is well known for bleeding because there is an increased bleeding tendency. Right. So now the severity again varies in DHF. There are some patients mild leaking, some get severe leaking or profuse leaking. So according to the leak, we can have 4 stages or 4 grades, 1 to 4. You can put these 2 red and 2 black I have put. Those 2 black ones are very milder form of leak. So even if it's like mild to moderate dehydration with the diarrhea patient, something like that. If they take adequate oral intake, even if they stay at home, grade 1 will not have any problem. But we don't know who will have grade 1, who will have grade 4. That's why we admit. Grade 2, again, not severe leak, but as I told you before, there can be bleeding. If they have, especially if they have menstruation, if they have taken any NSAIDs, or if they are more prone to gastritis as gastric or peptic ulcer disease, then they can bleed more. Grade 3 and 4 there is a strong risk of life, because their leak can be very severe and which can lead to shock, or that is compensated shock or profound shock. When you say profound shock, even blood pressure is unrecordable, pulse is not felt. But compensated shock, of course, you will feel the pulse, but very thready, very difficult to feel. Peripheries may be cold, but still you can count the pulse, you can record the blood pressure. But that is called compensatory. So grade 3 and 4 need to get extra attention, otherwise there is a risk for their life. So majority of patients we get in the ward are either dengue fever, or even if they are great dengue hemorrhagic fever, this could be 1 or 2. And also another problem we come across, problem or good thing, these patients maintain a very good consciousness. And even if they are in shock, you will see they can talk very well, and their saturation may be maintained because their lungs works very well. But so unless we feel the pulse, see the patient, examine the patient, we can easily miss shock. So one thing you notice, when a patient does not have a fever, the pulse is very rapid. When they have a high fever in 40, you can say the pulse is due to febrile fever, then you can give some paracetamol and see whether it's improving. But without any fever, if the child has a rapid pulse, then it's a impending shock. That is what I told, grade 3 shock, narrowing of the pulse pressure. 100 by 80, 100, you can see only 20 pulse pressure, 100 minus 1. Rapid or weak pulse, again they are more towards the collapse. Normal capillary filling time is 2 seconds. If anyone comes with more than 2 seconds, think about shock. They are restless and irritable. They don't want to hold the mask. They don't want to lie down. They are restless, irritable, and they are sweating a lot. Sometimes they behave very rudely. Their behavior is rude behavior, shouting. So all these are because of the hypoxia, or the blood supply to the brain is not adequate to maintain that. So as I told you, even in a shock or prolonged shock, you will see they are conscious. And most of the time they can tell the history, and saturation is preserved until last moment. So unless we feel the pulse and look for other things, we can miss. So the important thing during critical and leak or leaking phases, we have to match the fluid according to the leakage. If we don't match, they will go into compensated shock or decompensated. If you are worried and if you overtreat, the problem is they will end up with fluid overload. This is not like diarrhea or this thing. The fluid is still inside the body. So compensated shock, if you don't treat adequately, they can move into from compensated to decompensated in about few hours time. So we have about 1 to 3 hours to manage this compensated shock. Again, decompensated shock, if we don't treat adequately, they will quickly go into what we call irreversible shock that can lead to multi-organ failure, arrest, or death. In other words, what we generally tell is, if a patient has been in shock for 10 hours or longer, that is almost equal to death. That means even if they don't die in the ward, they will be sent to ICU with the multi-organ failure. In a 1 or 2 days, they might die. So the important message is the fluid loss need to be matched. How do we know how much fluid is leaking? From the monitoring. If we are worried about loss, we might give more fluid, but again, that can equally bad, that can lead to fluid overload. So what we need to do is just enough to maintain the circulation. We have to continue with the fluid. So shock is a clinical diagnosis. There is no instrument or no technology will tell you your patient is in shock. So history, examination. So tachycardia with low volume pulse, cold peripheries, prolonged CRFT, either the narrow pulse pressure or hypertension says your patient is in shock. So that patient has to be admitted to ETU because we don't want to delay the treatment. So there are flow charts in the guidelines, how to manage these patients. That I told you to 2023, we have revised the guideline. If you see how to manage, but at least the basic things like giving oxygen, IV cannula, basic investigations include inward PCV and blood for DTN grouping, and start with 0.9% saline, 10 ml per kg fluid resuscitation. And then you get the advice from the others. So you get patients to the ward, all infants, if they diagnose because of the high risk, we admit. Any child who has had a history of severe dengue, like tender hepatomegaly or something like that. I told you all the patients with comorbidities will be admitted early, sometimes social reasons. If they are reasonably well, other than the fever, we'll wait till the platelet count is below 150,000 to admit. But any child with features of shock should go to the emergency treatment. So in the ward, there are two kind of monitoring we do. One is when the patient admitted with 150,000, we go with the febrile or pre-critical monitoring. When the patient has a below 100,000 with gradually rising PCV and urine output start dropping, we have a doubt whether our patient has gone into critical phase. But serial ultrasounds can help. But remember, there are instances where scan did not show any leaking, but patient went into because of the who does it. There are so many factors, because if the leak may be small, but bleeding may be more, then the patient can go into shock early. So the clinical parameters still very important. Rising PCV and serial ultrasound scan might tell you whether plasma leakage is there. So whatever it is, once you start fluid management, monitoring, right interpretation and right intervention, and continue to monitor for about 48 or 36 to 60 hours to see whether your patient is stable. So monitoring, interpretation and intervention has to happen on a cyclical manner. So the critical patients are managed with hourly monitoring chart. And especially if the patient comes in shock, you have to manage them in the high dependency unit. There is a way to calculate the fluid. Again, if you are not clear in this lecture, you can go through your guideline. Maintenance fluid, there is a way to calculate. First 10 kilos, 100 ml, next 10 kilos, 50, and more than 20 kilos, 20. So if you take 50 kilograms, you can see 4,600 will be the critical phase fluid. So depending on the age, we calculate. And if the patient is overweight, we calculate for the ideal body weight. All these are given in the chart. So commonly we use an isotonic salt solution. It has to be used. If patient comes in shock, your calculated amount can be used over 24 hours, because shock can come generally somewhere in the middle of the critical phase. Very difficult to have shock in the early or very latter part. So because the leak is more during the middle part, so we take it as 24 hours. Non-shock patients, we take it as 48 hours, because roughly it can take 48 hours. As I told you, in about 36 hours, all clinical parameters are good. Patient is back to normal. All the features of recovery features are there. Then we can say this patient has recovered. There are only 3 types of fluid we use in critical phase. One is normal 0.9% sodium chloride. Other one is dextran and paclitaxel. Dextran and paclitaxel can be only given, dextran only given as a bolus. Paclitaxel, if there is indication for blood transfusion, 5 ml per kilogram at a time. So if we want 10 ml, first you give the 5 ml, reassess the patient. If necessary, we can go for the next 5 ml. So the crystalloid will be needed for all 100%, but colloid may be needed for about 15 to 30%, or packed red cells may be another 15. You can see there is no place for platelet or FFP or anything during this critical phase. When you are managing your patient reasonably well, that you are giving adequate IV fluids, all that, but your fluid quota is going to be over, but patient is not improving, think about these things, what we call simply ABCS. A is for acidosis, B is for blood bleeding, C for blood hypocalcemia, and S for hypoglycemia. So when your patient is not improving, I'm giving 10 ml, 2 boluses. Why my patient is not improving? You do a inward PCV and see whether blood sugar is normal, blood gas is okay. And if you haven't started calcium, you add calcium. If PCV is increasing, then your colloid may be dextran. If PCV is not appropriate for the patient condition, then consider concealed bleeding if nothing obvious. So signs of improvement, basically improvement in general condition. The mother will start saying, now child is feeling hungry, fever has come down, right? And the last few hours you see vital signs are stable. WBC has started to increase. Now platelet may be static going through. Now he is getting a confluent petechial itchy rash, right? And the urine output is with a minimal fluid, he is passing enough urine, then you know this patient is recovering. So these are the typical convalescent rash. You can see the red base with the white aisles. So recovery phase we identify with the general look. The child has got alert compared to resting active. Now there is no fever for more than 24 hours. Appetite returns, recovery rash appears, hemodynamically stable, and platelets start rising from very low level, gradually start rising. So this shows this patient is recovering. So you can stop monitoring if you haven't overloaded the patient. Causes of death. So why patients die? One is prolonged shock. As I told you, they are conscious, they are rational, they will be talking. So don't mislead by those things. You have to feel the pulse, CRFT, peripheries, and this thing. Otherwise, we can miss the shock. And sometimes we are scared of shock and we tend to give more and more fluid. There is a calculation of fluid, that is maintenance plus 5% deficit. Suppose it comes about 4,000, and if you have given about 6,000, definitely that is going to be more for that child. But 4,000 means 10% down or 10% up, it's okay. Beyond that, when you go, you might cause problem. And if the patient had been in shock for a long time, or in other words, I told you, one of the problems in these patients are increased bleeding tendency. Simple as this, if they have taken a steroid or a aspirin or mefenamic acid or ibuprofen, that is good enough to cause massive bleeding in these patients because they have a higher tendency to bleed. And then obviously, if we partially treat the shock, they can end up with multi-organ failure and die in the ICU after a few days. So in conclusion, high index of suspicion with dengue, any patient coming with fever, you have to have a high index. Regular monitoring with inward PCV and appropriate intervention. Please make sure you know how to do PCV and regularly do the PCV, because PCV is something which will help you during the critical phase, whether you are going to use dextran, whether you are going to give blood, or maybe even whether expected intervention or the appropriate intervention has led to expected outcome. Remember, dengue shock is an emergency. Without any delay, you have to start resuscitating. If not improving, I told you, think about bleeding, acidosis, any electrolyte imbalance like calcium, and think about the sugar. If you have given more fluid than much more than your calculated amount, remember to look for features of overload as early as possible and medically manage the overload. At the end, if we have a good team, good monitoring team, intervention, this thing, definitely we will have a good outcome and the case fatality can be brought down. Okay, thank you very much. I think that time I have taken about 5 minutes more. Since it is the last lecture, it doesn't matter. Okay then, thank you very much.
We discuss in next 30 minutes also about status asthmaticus. Status asthmaticus is inflammatory process that first we have to see what is the bronchial asthma. Bronchial asthma is an inflammatory disease. Actually, it's characterized by airflow limitation or airflow obstruction. How can we get it is there have a hyper responsiveness with bronchospasm. There is small muscle constriction and hyper responsiveness, which causes constriction of bronchi, and then there will be inflammation, which causes airway inflammation with mucosal edema and mucosal plugging, and next is mucosal hypertrophy or epithelial hypertrophy, which causes all three of them cause reduction of the lumina of the airflow, which causes airflow limitation or airflow obstruction. This pictorial representation is inflammation of airway. There will be inflammation and as well as airway hyperresponsiveness and airflow obstruction. With all those things ultimately result in clinical manifestation of bronchial asthma. In status asthmaticus is the worsening or severe form of bronchial asthma, which causes progressive worsening of bronchospasm, which leading to respiratory dysfunction due to bronchial asthma. It is severe form is respiratory worsening of bronchospasm and respiratory dysfunction due to asthma. It causes with status asthmaticus. Then there is unresponsiveness for standard or conventional therapy, which lead to progressive respiratory failure and may need mechanical ventilation or may cause death. That is status asthmaticus. Then this is a pictorial representation when artist got status asthmaticus. How he could remember is this, that the elephant line on his chest causes severe obstruction. This is a difficulty which he felt during an asthmatic attack or status asthmaticus. That is how difficult it is. First of all, I would like to draw your attention towards Poisson's equation. There you all know that is physics. Actually, that causes the resistance and the relationship between resistance and the radius of the tube and viscosity of the solution inside. Then there are 4 things that will be changing. Then this is R is resistance. Simple R is radius of the tube. Then En or eta is viscosity of the solution or gas or whatever. L is length. Then you can see that there is significant relationship between this the inverse proportionate relationship with the resistance and the radius. Actually, when it is radius is resistance is inversely proportionate to 4th power of radius. That is 4th power of it is inverse relationship. That means when you increase radius, resistance will go down. When you reduce the radius, resistance will go up. But it is not a single pole, it is 4th power of radius. That means when we double it, when we double the radius, that resistance will go down by 16-fold. So in other way, when we reduce radius by to half, resistance will go up by 16 times or 16 folds. And then there is significant relationship. It is very important to understand the relationship between resistance and radius. That there is this relationship is very important. In other way, that again this resistance is inversely related to 4th power of radius. That means when you increase radius by 2 times, the resistance will go down by 16 times. That means 16-fold reduction of radius when we increase resistance by 1 when we double resistance. That's very important. But that is that to understand the importance of bronchodilation in status asthmaticus. So asthma, if you can do a small dilatation of the radius, that there will be significant reduction of resistance. Small dilatation of radius, there will be significant reduction of radius. That is a important things of this understanding of this Poisson's equation and relationship between resistance and radius. It is very important. In again, the pathophysiology or the mechanism of asthma. Again, then there will be several things that is secretion or epithelial hypertrophy, then bronchospasm with all 3 causes cause this. This is a normal. You can see the normal airway in your this slide. Normal airway. There will be enough lumina. The next one is asthmatic airway. Then there will be hypertrophy of mucosal hypertrophy, and then that reduction of the lumina with the mucus plug-in and epithelial hypertrophy, and there will be airway hyperresponsiveness and bronchoconstriction. All of those things are there. That means this you can see clearly there is reduction of the lumina. That lumina is reduced in asthmatic airway. Then asthmatic then during attack or during status asthmaticus, during asthma attack, there will be further reduction of that there is tightening of smooth muscles, and then there will be further reduction of the lumina. Then further reduction lumina. That means if you can remember the previous slide, there will be significant increment of resistance. There is significant increment of resistance due to significant reduction of airway lumina. Then when we reduce some reduction of the lumina, there will be significant increment of resistance. Then you can understand the scenario that means there is significant air trap, air trapping in the distant airway or alveoli. Then that's what happened. Asthma, we have to identify acute exacerbation of asthma. That there will be we can categorize it to the easiness of the management or easiness. Then hari this disease that easy for easiness. There is you can categorize into several parts. So you can categorize that acute asthma into mild to moderate the severe asthma. Then mild to the severity mild to moderate exacerbation. Then other one is you can categorize into severe exacerbation and life-threatening exacerbation. First, we'll pay our attention towards life-threatening exacerbation. There, you have to identify this life-threatening exacerbation very early. Actually, there will be that silent chest, or that there will be poor response from the patient, and non-asthmatic with poor response. With you can see the cyanosis, or if you put the saturation probe, that will be reduced less than 92%, or that you can see clear cyanosis in this patient, or they have confusion or agitation. Then you are in trouble. Then that need early medical attention, or immediate medical attention. Then you have to discuss with your team. Then you have to do immediate action. In this one, actually, that we have to get other attention as well. Then in that it is that you most of the time you get this either moderate to mild to moderate attacks or severe attacks. Life-threatening attacks are there. We have to identify it early and treat it early. Then in other way, we have to identify mild to moderate and severe exacerbation as well. There, of course, you can identify by few things. One thing is respiratory rate. Respiratory rate is increase in both severe and mild to moderate exacerbation, with more increment in severe exacerbation. In less than 5 years, we can see it is more than 40. And if it's more than 30, increment is over 5 years children. Then again, saturation reduce in severe attacks, And mild to moderate attacks, even though there is increment of some respiratory rate, there's no reduction in saturation. Then there are minimal disturbances, and the child can complete sentences or feed well. Then there might be V's with the audible with visual scope. With severe attacks, you have to identify it very carefully. That saturation is not maintained with oxygen, with atmospheric oxygen. We have to support with oxygen to maintain saturation. They are actually increased respiratory rate more than 40 in or less than 5 years, over 500 to 5 year children, and over 5 year children is more than 30. And that very difficult to talk, and very difficult to do the feeding, and as well as very difficult to complete the sentence. And there will be increased respiratory heart rate as well in severe attacks. Then you have to identify mild to moderate attacks, severe attacks, and life-threatening attacks. Life-threatening attacks you have to identify and do medical attention very early. Then we have to after identification of the acute asthma, then we have to follow, we have to do treatment accordingly. This is the treatment plan I am going to discuss in next few minutes. Then we'll move on to this management. First of all, we have to do the general care. If there is main need of IV access, so that we have to simultaneous these are not we are not doing it separately. We simultaneously we do this thing. We assess the patient. If there is a reduction of the oxygen, we have to straight away we have to go for the oxygen first. And meanwhile, if there is need of severe attacks or life-threatening attacks, we need IV access. And in mild to moderate attack, we don't need IV access. Actually, we can do without IV access. And then we need continuous cardiorespiratory monitoring, and that we have to do the continuous pulse oximetry in acute severe asthma and life-threatening asthma. Then there are children who require mechanical ventilation. We have to do the further support by catheterization and as well as venous access. Then oxygen is one of main drug that is used in one of the main drug that is which is used in bronchial asthma and exacerbation. And there is a significant VQ mismatch, which causes reduction of the saturation that is there in asthma in acute exacerbations. Then that's why we get severe asthma and life-threatening asthma. Because of that, we have to supplement oxygen. And then at the giving oxygen, there are few things that there will be hypoxic pulmonary vasoconstriction, which will improve with oxygen. Other one that is again we can combat VQ mismatch. Another one is there will be some bronchodilation effect as well. That is also contributed to treatment of asthma. Then because of that oxygen, giving oxygen is must. First and foremost is VQ mismatch, and because of that we get reduction of SpO2. Because of that we have to give oxygen. Then additionally there will be some other effects as well. Therefore, oxygen is first we have to administer oxygen, and as well as we have to give oxygen till this acute phase is over. Then there is where is this asthma that usually we can this bronchiolar region. This area is getting constricted. This we have to trachea and upper section is not usually not involved, but here it's middle part is involved in bronchial asthma. Then fluid, actually in bronchial asthma, because of increased respiratory rate and with illness, they are so often they are dehydrated. The other one is because children ill, therefore reduce oral intake and vomiting, and those things will be there, and increased respiratory rate, more evaporation, of more loss of insensible loss is high in increased and the appropriate resuscitation should be done. And then we have to be careful in mind this. We have to avoid overhydration, or that may cause increased microvascular permeability and pulmonary edema. Therefore, we have to give fluid, but we should not overhydrate these children. Then corticosteroid, that is the mainstay of treatment. And this is we have already discussed. There is inflammatory disease. That means we have to reduce the inflammation. To reduce the inflammation, we have to give steroid. Steroid is must, or we have to give steroid for asthma. That in acute, especially acute moderate asthma and acute severe asthma and life-threatening asthma, we have to give systemic steroid to combat inflammation. That is the mainstay of treatment. That is main therapy is steroid. And there are several actions. You can suppress cytokine production, the suppress GMC stimulating factor, and there will be reduction of the nitric oxide production. There's inflammatory cells and mucus production, all vascular permeability, all are reduced with asthma. Therefore, we have to give steroid in asthma. Then type of steroid is IV steroid is the in acute severe asthma and life-threatening asthma is acute steroid. In mild to moderate asthma, it is you can give oral steroid as well. But as we talking about status asthmaticus, it is either life-threatening asthma or acute severe asthma. That means we need IV steroid. And there is place for inhaled corticosteroid. It is also in mild to moderate exacerbations, not for severe and life-threatening exacerbation, because we can't give inhaled corticosteroid because it's very difficult to give inhaled steroid in this situation. Type of corticosteroid, still there is no proper consensus. So what is the best corticosteroid is? However, in most of the people, they like IV methylprednisolone. It is commonly used agent, and also IV hydrocortisone, IV dexamethasone also we use, and but IV methylprednisolone is one of the commonly used agent, and it is because there is the limited mineral the belief of there is some belief that limited mineralocorticoid effects. Because of that, methylprednisolone is prepared over the steroid, but it is very controversial. That initial dose is in methylprednisolone, it is 2 milligram per kilogram, followed by we have to give 0.5 to 1 milligram per kg per dose IV every 6 hourly initial pace, but then we can change it over to oral steroids. Then after giving steroid, there will be few hours to we have to wait for a few hours to see the action. Because of that, we have to buy our time. For that, we have to give oxygen. Then we have to do the bronchodilation till this corticosteroid act. After getting the proper action of the corticosteroid, there will be a reduction of the inflammation and reversal of all this inflammatory process. But we have to wait till this for a few hours. Therefore, we need other things, that oxygen and bronchodilation, till we get this corticosteroid action. This corticosteroid actually usually take actually at least 1 to 3 hours to reach the maximal effect. That at least then to reach the action, the 1 to 3 hours to see the action, then the 4 to 8 hours to get the maximal effect. Then after administration, it will take at least 4 hours or 6 to 8 hours to get the maximal effect. Therefore, that is the main drug, but we have to wait for some time to get the action. Then we have to continue this corticosteroid till the asthma exacerbation is resolved. It is not for one dose, but we have to continue it till the exacerbation is resolved. That is the other thing that you have to know. Then side effects of side effects of corticosteroid. There are many side effects: hypoglycemia, hypertension, and there will be several side effects will be there. But we have to administer corticosteroid during asthma attacks. Early steroid therapy is very useful. Then, as I mentioned earlier, that we have to do bronchodilation till we get this steroid action. Then one bronchodilator is salbutamol. As we all know, that is beta agonist. Then there is bronchial smooth muscle relaxation, and through its symptomatic agent. And then there will be you can use inhalers, and you can use nebulization and nasal IV solution. Inhalers actually mild to moderate exacerbation, we can inhale salbutamol through MDI. But in status asthmaticus, actually in severe attacks, on life-threatening attacks, we can't use inhalers. Then there we have to use either nebulization or IV solution. Nebulization is the most frequent used modality. There's continuous nebulization is very important. We have to remember, we have to do the oxygen-driven nebulization. We have to do the oxygen-driven nebulization because one thing is we get vacuum mismatch, carbon dioxide inside this alveoli. Therefore, if you do nebulization without oxygen, there will be significant sudden reduction of the saturation, or there will be hypoxemia and hypoxia will be there if you use nebulization without oxygen. Then other thing is IV salbutamol infusion. We fail this nebulization or difficult nebulization. IV salbutamol may be effective in treating acute exacerbation or status asthmaticus. Then that is one of the mainstay of therapy is infusion. Then dose is usually 1 to 10 micrograms per kg per minute. We can start with a small dose and we can gradually increase according to the response. The salbutamol has many side effects. That tachycardia, palpitation, those things, tremor will be there. They will be transient. But we have to monitor hypertension and hypotension as well. Then ventricular cardiac arrhythmias we have to monitor with the monitor. We have to attach all the probes. Then we have to make sure that child is not getting hypokalemia. Hypokalemia is one of the problem in salbutamol infusion. Then we have to give supplement. We have to supplement potassium to reduce or minimize hypokalemia in salbutamol infusion. It's very important. Magnesium sulfate is a very important drug. it is now commonly used drug. Then it is magnesium sulfate has many effects, that bronchodilator effect, that is calcium channel blocker, and there is because of blocking of calcium channels, then there's activation activation of adenosine cyclase in smooth muscles. There will be smooth muscles relaxation because of this magnesium sulfate. Therefore, there is bronchodilator effect in magnesium sulfate. That in other hand, magnesium inhibit calcium mediated smooth muscle contraction and facilitated bronchodilation. That is that's the action of magnesium in status asthmaticus. Then it is very important to get this action. Then the other thing is there will be respiratory muscle stabilization by giving, because you know that there's increased respiratory rate that and using accessory muscles, and there will be exhaustion of the muscles, and with the increased respiratory rate, because of that there is impending paralysis of these muscles, because exhaustion and cramps and all. Then by administration of the of magnesium sulfate, we can alleviate that thing, and we can stabilize respiratory muscles. This is very important in status asthmaticus. Then dose is 25-50 milligram per kg. This usually administered over 30 minutes. We can administer even every 4 hours by continuous monitoring. This continuous monitoring is very important, because there are side effects like hypotension and CNS depression and the muscle weakness. Then because of that, if you do this intervention, actually this ill child status asthmaticus, and even you give salbutamol infusion or even magnesium sulfate or any drug, we have to monitor this child anyway. And especially when you give the magnesium sulfate, you have to see features of CNS depression and hypotension and muscle weakness. Those things we have to monitor throughout the period. We have to be very careful. We have to monitor these children when we give magnesium sulfate. And continuous infusion also we can give, but we can give the boluses in every 4 hourly or every 6 hourly. We can repeat this, but usually in first 2 doses we can get the response. Then methylxanthines, it is aminophylline. Actually, what is widely known, this aminophylline infusion, that methylxanthines can be used in status asthmaticus, and it promote relaxation of smooth muscles. That there is some strengthening of the respiratory muscles as well, but the mechanism of action is remain controversial. That there are several mechanisms suggested, but it is controversial. In theophylline is oral preparation. It is not, we can't use it for status asthmaticus. The aminophylline is the one we use for status asthmaticus as continuous IV infusion, followed by the initial loading dose, followed by continuous IV infusion. Because of this narrow therapeutic index, secretion will be reduced with that anticholinergic effect, and there is reduction of the respiratory secretion, and there is promote bronchodilation as well. Therefore, there is additional effect from this infratropium. This usually it is aerosol mode. It is nebulization, or we can give the MDIs as well, but then MDI usage in status asthmaticus is limited. Therefore, the inhaled or nebulization of ipratropium bromide is the method we can use in status asthmaticus. There are ipratropium bromide has few systemic side effects because there is poor systemic absorption. There's poor absorption to systemic circulation, therefore few adverse effects. Again, I want to remind the Poisson's equation. Then initially we discussed about radius. This with the bronchodilation, as I mentioned earlier, there is some increment of the radius will cause significant reduction of the resistance. Therefore, bronchodilation is very important in managing status asthmaticus. In other way, then other things that length of the tube we can't reduce. Then viscosity. Again, there is sometimes we can use reduction of the viscosity as well. Then reduction of the viscosity, again there is the reduction of the resistance. It causes reduction of resistance. But more importantly, we have to do the increment of the radius. Then that will reduce resistance significantly. Density and viscosity actually when we density per mass unit volume, and then if there is significant reduction of the viscosity and or increase the that will when we reduce the reduction when we do the reduction of the viscosity, that will improve the flow actually, again reduce the resistance. Then helium oxygen, actually low viscosity gas with reduced airflow resistance by reduction of the gas viscosity. And there is attractive, this is one of the attractive therapeutic option, because usually we talk about this bronchodilation and all those things, but here that HELOX, that helium oxygen, then which causes which actually theoretically causes reduction of the viscosity. Then in theory we can see there is reduction of the resistance as well, but there is no significant benefit that by using helium oxygen. Therefore the usages remain controversial here, because it could be due to that single fall reduction, that in comparison with the radius, in radius actually there is fourth power of radius we can reduce by many folds by increasing the radius. If there is no improvement after therapy, that we so far we have given the oxygen, and at the same time we did the nebulization. At the same time, we started corticosteroids. Then there's no improvement. We get the IV access and started on magnesium and IV salbutamol. Those things we have used. Then if there is no significant improvement by with the initial management, we have to see whether there is other complication like pneumothorax. So again, pneumonia, or we have to see our diagnosis. It could be, though we are thinking about this status asthmaticus, it could be ARDS or some other diagnosis, or our diagnosis is wrong. Then we have to consider these things. There is no improvement. Here you can see there's left-sided pneumothorax in this patient. Who has the status asthmaticus. There is poor improvement. Then after evaluation, we could see we could see pneumothorax in this type. Then there is poor improvement after initial management. There's continuous the progressive diseases. Then we have to go for ventilator support. First of all, we have to try with non-invasive mechanical ventilation, either BiPAP or CPAP, which may prevent tracheal intubation, because the intubation is when we see intubation compared to other diseases, there is increased mortal rates with intubated children with status asthmaticus. It is when we do the intubation, the mortal rate will high in comparison with other diseases. Therefore, if we need the ventilator support should be kept to last resort, and if we need mechanical ventilation, we should use non-invasive ventilation rather than invasive or intubation. Because intubation, that asthma is heterogeneous disease. There's different alveoli dilated in different way. It is very heterogeneous disease, and because therefore we have different sizes of alveoli. Some alveoli are over-distended, some alveoli collapse, some alveoli is partially obstructed. Therefore, it is very heterogeneous. Then we deliver pressure from mechanical ventilation or intubation. There will be application of pressure will be different to different alveoli. Therefore, there will be volumetrauma, barotrauma, and causing pneumothorax and those problems. Then mechanical ventilation causes problem in mechanical in status asthmaticus. But we have to consider intubation when there is hypoxemia despite provision of high concentration of oxygen, then severe unremitting work of breathing, when we have to consider intubation, or then altered mental status and respiratory or cardiac arrest, we have to consider mechanical intubation. However, we have to do the initial management, and we have to keep this mechanical ventilation into last resort. Then if you need intubation, it is very risky, and we have to do it very careful. Then we have to prepare for intubation. We do it with very care. And then it is anticipation is very important, because we have to do the intubation with most skilled person individual in the unit. Then we have to be ready for hypotension, because there is hypovolemia in this child, and reduced vascular tone by several anesthetic agent as well as bronchodilator agents as well. Then venous return is impaired because of the positive that increased thoracic pressure. Therefore, that child can develop hypotension in status asthmaticus. Therefore, intubation, during intubation, there will be collapse or hypotensive episode in this child. Therefore, we have to be very careful during intubation. Then we have to use, we can give fluid bolus and to improve the vascular volume. And we have to use a cuff tube during intubation, because we have to use cuff tube with largest diameter for appropriate for this child. It is to alleviate high ventilator pressure. Drugs during intubation, that we should not use morphine or atacurium during intubation, because atacurium causes histamine product agent. Then we can give more and more bronchoconstriction and more and more effect of worsening of the condition. The ketamine is excellent agent, because that it has longer half-life and bronchodilator effect, and hemodynamic stability is maintained with the ketamine. Therefore, ketamine is a better drug for induction of the anesthesia. Again, we have discussed these things in previous slides. We have how to give the oxygen, and the modality of nebulization, bronchodilation, Then IV agents, IV magnesium sulfate or aminophylline or IV salbutamol. Then we have discussed about mechanical non-invasive ventilation and mechanical ventilation and intubation as well. Then at the last resort, that if we have facilities in that is what we can go for ECMO. And the ECMO has better outcome in compared to other diseases in hysteresis asthmaticus, because if you go do this ECMO till in mechanical ventilated hysteresis asthmaticus, we can get a better outcome. But we have to do the initial management, early intervention, and we have to limit our intervention to initial therapy, that initial management. We have to make sure that we do correct things and immediate quick actions and limit the disease at early stage. Then at last, actually, this hysteresis asthmaticus early identification is very important. We have to identify it. If we can identify by mild to moderate attacks, then it is very important. And severe and life-threatening attacks, we have to identify from identification of the attacks as well. The hysteresis asthmaticus. Then oxygen-driven nebulization is very important, because we can hypoxia. Intractable hypoxia, we do not use oxygen during nebulization. It's very important to use oxygen driven nebulization. Then magnesium sulfate, this very important agent, we should consider it early. Early usage, we can get good action. Then intubation and ventilation, we should not do it, or we should keep it for the last resort. Thank you. Thank you.
And the tonicity is the relative to other solution. So mainly depend by the solute. So now we can understand this part too. Now say this is the cell. So it's the plasma. It's outside the cell. So if the solution is outside the solution osmolality is lower than the plasma, that means it's a hypotonic solution. If the osmolality is both same, this is isotonic, and if we have a higher osmolality, is hypertonic. So tonicity is a relative term. So usually in relationship with the plasma, if less than plasma, it's hypotonic. Same as plasma, isotonic. More than plasma, it is hypertonic. So if you have a solution is freely movable, so we say glucose, dextrose is there. So we are having huge amount of glucose here. So 5% dextrose, osmolality is 286. So iso-osmol. So osmolality is same as plasma, but this glucose can cross the plasma and go to the intracellular compartment. So it's really movable. So relatively, basically, they cannot produce any osmolality. So it's isoosmolar but hypotonic. So you can't say its tonicity cannot be maintained because this glucose molecule is crossing the plasma. So isoosmolar solutions, they are not isotonic. So this is these are the solution that we have. You will understand sodium. The normal saline has sodium of 154. Osmolality is 308. It's 2 times sodium. So it's isoosmolar, isotonic. Half normal saline 77. It's 154. Hypoosmolar, hypotonic. But look at this: 5% dextrose, no sodium at all. But osmolality is 286. So it's isoosmolar. Osmolality is same, but it's hypotonic because this glucose molecule is shifting from one gas to other. Half normal saline with 5% dextrose, that's a sodium of 75, but the osmolality is 430. It's a hyperosmolar. When you're comparing with the plasma osmolality is very high, but you cannot say it's the tonicity is hypotonic because this osmolality is mainly due to sugar. The 1/5 normal saline with 4% dextrose is isoosmolar, hypotonic. Normal saline is 5% dextrose, hyperosmolar, but isotonic because we have 150 millimoles of sodium. Reverse lactase, isoosmolar, isotonic. What you have to understand is all the isoosmolar solutions are not isotonic. Right. So then what will happen to the cell in various solutions? So if you have an isotonic solution, there's no fluid shift from either side. Fluid is not going into the cell, fluid is not going outside the cell. So if you're having an isotonic solution, cell is very happy, it's safe. If you have a hypotonic solution, the tonicity is lower in the outside solution. So more fluid will go into the intracellular compartment, cell will swollen up. If the cell is in hypertonic solution, fluid will shift from intracellular to extracellular compartment, can cause shrunken up of the cell. So with this background, you can think about this. So hyponatremia definition is sodium is less than 135. Usually you get symptoms with the symptom the sodium is less than 125 or serum sodium has fallen rapidly. So this is you can see that it's a normal brain, it's a hyponatremic brain. How can we prevent hyponatremia? No hyponatremic IV fluid, always use normal saline. Whenever possible, go for enteral feeding because body will handle these things very effectively. Normal saline with 5% dextrose as maintenance IV fluid, especially if you're having a high antidiuretic hormone secretion. And more than 50% IV fluid at least twice a day, you have to do serum glucose. So these are symptoms. I'm not going to go into details. You know these are neurological symptoms. The principles of management are these: if the hyponatremia is symptomatic, treat urgently and rapidly. If asymptomatic, treat slowly. Frequent electrolyte monitoring is a must. So symptomatic hyponatremia, ABC is a must. Then increase your sodium up to 125 quickly. So you can use 3% saline, usually 3 to 5 ml per kilo as a bolus, 15 to 30 minutes. You can increase sodium by 3 millimoles per liter. Usually stop seizures. So usually the symptomatic hyponatremia means child is having convulsion or drowsiness due to low sodium. Repeat if ongoing seizures. And our aim is to increase sodium over day, over 24 hours. The maximum is 8 millimoles per day. 8 millimoles over 24 hours is our aim. After you are changing symptomatic hyponatremia into asymptomatic hyponatremia. So again, if there's symptomatic hyponatremia, treat rapidly, increase your sodium up to about 125 quickly, and after that, correct slowly. So maximum correction should be 8 millimoles per liter per day. So asymptomatic hyponatremia, depending on volume status, no dehydration, no dehydration, severe dehydration, active correction of 3% saline is not necessary. Slow correction is the aim. So again, the aim is 8 millimoles per liter per day. Asymptomatic hyponatremia with normal or increased volume status, restrict water to slowly remove the increased body water. Do not use hypotonic solution. Asymptomatic hyponatremia is moderate dehydration. You can use NG rehydration with ORS. If not tolerated, IV rehydration with normal saline. And this is very important thing because now we think ORS contains a lot of sodium, but ORS sodium contains about 75 to 90 millimoles per liter. So that is also hyponatremic. Think about the reality. So asymptomatic hyponatremia with severe dehydration. So rehydrate with normal saline. Give 0.9% normal saline plus 5% dextrose until the child can take orally. Ensure electrolytes every 4 hours until stable. And again, why we are correcting very slowly. That is also very important to understand. Now think. So this is what happens in isotonic solution. Already we have discussed. In isotonic solution, cell is very happy. Nothing will happen. So when you're on hypotonic solution, or normal saline, hyponatremic solution, the fluid will shift from extracellular to intracellular compartment, and it is fallen up. So with time, body will not wait without doing anything. So there will be adaptation. That means body will shift various ions outside from the cell. So now it is in the equilibrium. Now all of a sudden, you try to increase the sodium level. So now body is adapting to this new condition with hyponatremic environment. Now all of a sudden, if you correct this, increasing the water from intracellular compartment. So this is called syndrome of osmotic demyelination. So rapid correction of hyponatremia is that. That is why our aim is 8 millimeter the hyponatremia, not in acute stages. So if you're having a symptomatic hyponatremia, treat rapidly. If not, it should be very slow. Hyponatremia, mild hyponatremia is a common risk increases level of serum sodium. Treatment can be complicated and potentially dangerous. You need to seek expert advice early. And definition, going quickly because we have going behind time. And mild hyponatremia is 146 to 149, moderate 52 to 69, severe more than 170. Management, again, a too rapid correction should be avoided. Too rapid correction can cause severe edema, conversion, permanent pain. Hyponatremia solution. That's the key. The treatment of hyponatremia is not hyponatremic solution. It's always not. The fluid management based on the initial serum sodium. So mild requires so in hyponatremic dehydration, you are trying to replace the fluid deficit over 48 hours. So it's like AKA. So you are not rapidly correcting, and it should be normal. Severe hyponatremic dehydration that is more than 170 is a medical emergency. So you need tertiary referral, contact ICU, initial resuscitation, after initial resuscitation, replaced by deficit over 72 to 96 hours. That means very slow correction of the deficit, because rapid correction will cause a edema and kill the child. So always with normal saline. So we are using normal saline. So it's very simple in the management of hyponatremia. We have to consider peritoneal dialysis if the sodium level is more than 180. In hyponatremia, the aim for slow correction. So initially I told hyponatremia, the correction is 8 millimoles per liter over 24 hours. Here is 12 millimoles per liter over 24 hours. That means 0.5 millimoles per hour. Because 12 millimoles doesn't mean that it's now the sodium level is 152 and I want to reduce. First 11 hours, yeah, we have not reduced. Within the next hour, you can't reduce by 10. Right? It should be very slow. It should be 0.5 millimoles per hour. And no place for hyponatremic solutions. Always use normal saline. 4 to 6 hours electrolytes. 6 expert advice. So Diabetic ketoacidosis, already we have discussed. I'm not going to go into detail. Same thing. Right. Dengue. So again, dengue that day we discussed. You have seen this slide again and again. This is similar in literature. This is the patient present picture. This is how you should manage. And you've seen this. So type of IV fluid. Always I will isotopic steroid for infusion of boluses. Hydrogen colloid only for boluses. Indications of colloid discuss colloid administration. All these slides you have seen. Hypernatremia is common. Right. So this is important. Suspected or raised ICP. So meningitis encephalitis, when you are managing a child with a suspected or diagnosed raised ICP, the main aim is to maintain the cerebral perfusion pressure. So this is the relationship of pressure. So cerebral perfusion pressure is mean artery pressure minus ICP. So this is my mean artery pressure. This is ICP. So what I want is to increase mean artery pressure, decrease ICP. So to increase mean artery pressure, I can use volume, I can use inotrope, I can use vasopressor. To decrease ICP, I can use hypertonic saline, mannitol, EVD, training. So these are the options. So if you think about the mannitol versus hypertonic saline, mannitol, yes, is osmotically active. It can reduce, but at the same time, it's a vasodilator. It will reduce MAP. It's a diuretic. It will reduce MAP. So mannitol will reduce MAP as well as ICP. So our aim is not to drop ICP alone. We want to maintain, we want to increase the cerebral perfusion pressure, CPP. So if you think about the CPP, ultimately what will happen to CPP? We don't know. In contrast to the 3% saline, it will increase the MAP because it's like normal saline, and it will decrease the ICP. So two ways it will increase cerebral perfusion pressure. So definitely we know that we are going to increase cerebral perfusion pressure. So always 3% saline is better than mannitol in the management of cerebral. So how much fluid that we should give in meningitis? Maintenance versus restricted fluid. So there's a big argument about this. So most of the places what happens is as soon as you diagnose the meningitis or encephalitis, you give only 80% fluid. So that should not happen because the main killer is not maintaining the cerebral perfusion pressure. So this is the Cochrane review about that. So they have discussed about maintenance fluid versus restricted fluid. So no significant difference in number of days, but the significant difference in spasticity, seizures, chronic severe pneumonitis sequelae at 3 months follow-up. So there's no difference between the death, but there's a significant difference in the morbidity. So maintenance fluid is given. So whenever you are managing meningitis, encephalitis, please use maintenance fluid. So meningitis, encephalitis, always normal saline, no hypertonic fluids, no fluid restriction, at least maintenance fluid, sometimes fluid boluses. And to maintain cerebral perfusion pressure, 3% saline is better than mannitol. So about the IV fluid, these are take-home messages. Press strike IV fluid as medicines. Oral fluids, very, very low in sodium. And any child needing IV fluid, risk of hyponatremia due to high antidiuretic hormone. If ill oral, add glucose IV fluids, Texas name of normal saline. Frequent monitoring and assessment, ready to change your treatment plan frequently. Select the IV fluid, rate, and volume depending on the disease result.
Today's session enough. Tomorrow, please tomorrow join 8:30 p.m.